Assalamualaikum warahmatullahi wabarakatuh. So good morning, everyone. Good morning, all the participants of the 16th Virtual Postgraduate Forum on Health Policy and Systems. So today is the second day of the pre-conference, and we have 3 short courses today. So warm greetings from very warm Yogyakarta this morning. And I'm Likke Prawidya Putri. I'm your host for today. So the title of our short course this morning is Conducting Cost Effectiveness Studies Using TreeAge Software. We already have here our distinguished speakers or trainers, Professor Dato, Dr. Syed Mohamed Aljunid, Dr. Amirah Azzeri, and Dr. Mohamed Hafiz bin Jaafar. So all of them from University Kebangsaan Malaysia. So first of all, let me share the rules for the participants. So for all the participants, please use your registered name as the Zoom name. And also for the certificate, please fill the registration link that will be shared by the committee today. And also make sure that you already installed the TreeAge software before we start the training. Now, maybe first of all, I'd like to check. Good morning, Professor Syed Mohamed Aljunid.
Good morning, and everyone. Thanks for arranging this. Yeah. I have all the speakers with me. I think Amirah and Dr. Hafiz.
Yeah, okay. I'm just ready for you. So before we start, let me introduce all of our speakers today. For the committee, please, would you please share the screen of the, okay, thank you. So we have Professor Dato, Dr. Syed Mohamed Aljunid. He's a professor of health economics, policy and management of the Faculty of Public Health, Kuwait University, and also professor of public health medicine and health economics, and also founding and head of the International Center for Case Mix and Clinical Coding Facility of Medicine, Coding Faculty, in University Kebangsaan Malaysia. He was the first Malaysian to be the professor of health economics, and he got his PhD degree from the London School of Hygiene and Tropical Medicine. So some of his work experience is co-chair of Morbidity Technical Advisor Group of ICD-10 revision of WHO Family of International Classification. Also executive council member of Patient System Classification. And he is also the deputy president of the Public Health Medicine Specialist Association of Malaysia. He will share the topic of introduction to economic evaluation. So next trainers or speakers, we have Dr. Amirah Azzeri from University Sains Islam Malaysia. She obtained her Doctor of Public Health degree from University of Malaya. And she graduated with Master of Public Health degree from University of Sydney and MBBS degree from University Sains Islam Malaysia. So today she will share about using the TreeAge software. And for our last speaker, we have Dr. Mohamed Hafiz bin Jaafar. I'd like to check whether Dr. Mohamed Hafiz already here and Dr. Amirah. So Dr. Mohamed Hafiz bin Jaafar has his degree of Doctor of Public Health from University Malaya, Master of Public Health degree from University of Sydney, and MBBS degree from University Sains Islam Malaysia. Some of his work experience is the Chief of Research and Innovation Group and also a sponsor committee for academic program offering master and doctor in public health, secretary of occupational safety and health committee, and professional examination committee and of academic session in the faculty. So before starting the session, I'd like to check whether all the participants has installed the TreeAge software. Please give your thumbs up if you have installed it. The committee. Okay, so can we move to the gallery view, Mbak Lia? Yes, I'd like to check whether. Yep. So, is there any? Yep. Is there anyone haven't installed the software? You can please raise your hand if you have not. Okay, I think everyone has the TreeAge software installed. So without further ado, please Professor Aljunid, Dr. Amirah, and Dr. Mohamed Hafiz, the time and place is yours. Thank you.
Thank you so much, Madam Chairperson. Can you all hear me? Okay, good. I will start off the pre-conference workshop. I'll be accompanied by two other speakers, as mentioned earlier, Dr. Amirah and Dr. Hafiz, and they will be helping us in this workshop. And before I start, let me just inform everybody that we have no direct interest on the software that we mentioned here. We are all the users of the TreeAge software, and we use that quite a lot, and we want to share with you. We have no interest in marketing or in asking you to purchase the system. It's up to you whether you want to use it or not. We are just one of the users like any one of us. I will share my slides now to keep you update on what we are going to do in the next 3 to 4 hours. So before we start, these are the topics that we try to cover. This is just an introduction, and you need to actually later on deal with more detail on how to use this software to conduct cost effectiveness analysis. I will start off the ball rolling by giving you an overview on how to conduct economic evaluation, and the focus will be on cost effectiveness analysis. And then Dr. Amirah will continue with the economic modeling, which is very common now, being used in many countries. And she will also introduce you with the how to apply and use this software. And then followed by a short practical session on the use of the TreeAge software. And Dr. Hafiz will come in at the end of this workshop to guide us on how to interpret the result from this cost effectiveness model. So let me just go through these topics on the introduction to economic evaluation. I will talk about why we need economic evaluation now, the different type of economic evaluation, the steps that we do cost effective analysis, and then we will talk about cost analysis, which is the one main component of CEA, and how we measure the effectiveness followed by sensitivity analysis. I will share with you our latest study, which have just been completed last month on cost effectiveness of flu vaccination, which we conducted in Malaysia to support the decision-making process of introducing flu vaccination as a part of the public health program. So why do we need economic evaluation? Of course, one of the important aspects of economic evaluation is that the information can be used to assist decision-making process. Policymakers look for economic evaluation data to guide them. And it's very important because by having economic evaluation data, it will guide the policymakers on how to deploy scarce resources, especially we talk about human resource, time, and of course, financial resources. And by having a good economic evaluation data, it will help us to run away from unsystematic analysis, for example, just by making a decision based on our educated guesses, what some people say, gut feelings, and also what they have experienced before. And sometimes this may not be evidence-based at all. However, you must always remember that at the end of the day, the allocation of resources, even if we have economic evaluation, is still being influenced by many factors, including political, social, cultural, and also the economic factors by itself. Because even if the study shows that it is cost effective, sometimes the country may not have, or the MOH may not have enough resources to implement the cost effective measures. These are different types of economic evaluation. It grows from time to time. The main component of economic evaluation is cost analysis, and we have cost minimization, cost effectiveness analysis, which will be our main focus for today, cost benefit analysis. And increasingly, we been requested by policymakers to look into economic burden and also budget impact analysis of new intervention. Cost is very important, and it is common in all kinds of economic evaluation. Without cost, you will not be able to proceed with any economic evaluation, cost effectiveness, cost benefit, or even cost minimization analysis, budget impact, and all that. So by having information on cost, we will be able to actually create cost consciousness among practitioners who are practicing in the field. We'll be able to compare cost of managing diseases from time to time. And if we are talking about contracting out the services to other providers, we must know the cost so that we know how much to pay them. And if we are planning to build healthcare facilities, cost, of course, is an important factor. We want to build facilities which are economic enough to actually provide services according to the high level of efficiency. In cost analysis, only the costs are calculated. It is also called partial economic evaluation. But I want to stress here, this is the most common form of all economic evaluation. And cost minimization analysis is a special form of economic evaluation where the cost and outcome are being measured. But here the outcome that are being compared are actually assumed to be the same of various options. So at the end of the day, if we manage to do this and we manage to get intervention that produce almost similar outcome, then we only compare the cost. And that's why we call cost minimization analysis, because finally the policymakers will choose which one is actually the least cost. But this is not common because it's not many. We don't have many instances where the outcome will be the same for various intervention, and this is not that commonly being done. Cost effectiveness is the most common probably form of economic evaluation. It is called full economic evaluation, where you compare the cost and the outcome, and you compare at least another alternative. So you must have at least a minimum of one alternative, minimum of two alternatives that you are going to compare, and then your result will be expressed in terms of costs per unit output, or we reverse it, effects per monetary units. Cost benefit analysis, sometimes this is being done in as one of the ways to do economic evaluation. It's not that common. The reason is because in cost benefit analysis, both the cost and the benefit are in the cost and the outcome are in monetary terms, and it will run into issue of controversials when we try to put the outcome, especially we are talking about the human life situation, into monetary value, and that is the issues that we come across if we are going to do cost benefit analysis. It is a very important, very powerful tool, because cost benefit analysis will tell us how much can we get in terms of the return of investment with the intervention. Anything? So in order to conduct cost effectiveness analysis, first we need to actually formulate the research question, define the various alternatives, calculate the cost, you calculate and then you measure the outcome, and then you calculate the cost to outcome ratio. And finally, to make the study more robust, we need to do the sensitivity analysis. In cost analysis, there are 5 important issues that we need to consider when we are doing the economic evaluation. We must decide which cost to be considered and from whose viewpoint, because if we are talking about the viewpoint of the providers, then the cost from the patient perspective may not be included. But if you include everybody's, then we call societal perspective. More commonly, we are doing it on behalf or on the perspective of government, which is actually Ministry of Health. So in other words, the cost that incur on patients may not be included in the analysis. We need to know how we are going to estimate the cost and how accurate the costing should be. This is again another issue. We must always remember that there's no such thing as true cost. What we know is actually the best estimate of the cost. There's always be variations when you do this costing analysis. And the last point that we need to consider is how to handle capital outlay. This is the capital cost, where the equipments and where the cost is actually runs over a period of more than 1 year, and you need to find ways to do that. How do we measure estimate costs? There are various methods, including observation, getting from expert panels, but we are more commonly quite well sort of in tune towards doing a cost analysis study using 2 main methods, which is the activity-based costing or step-down costing. Both have strength and weaknesses. It is not we're not going to discuss this in more detail in this short course. When we want to handle capital costs, we must look at the lifespan of the capital equipments, buildings, and all that, and we need to actually annotize it to get the equivalent annual cost. And we use discounting table where the discount rates are being used in order to manage this, which covers inflation as well as the cost of investment. And that is important aspect that we have to answer. The next sort of component of cost effectiveness analysis, how do we measure effectiveness? It is very important for you to choose a good outcome for which is relevant to the policymakers when they make decision. The final outcome, like for example, life years gained or number of deaths averted, is much easier for us to understand. But sometimes we use intermediate outcome, for example, number of cases being detected, especially when we are talking about using doing this analysis for a screening test, for example, or millimeter blood pressure reduction if you are looking at the effectiveness of certain drugs. If we are choosing intermediate outcome, you must make sure that the intermediate outcome have a direct link with the final outcome. Then it will lend more credibility to this data. Increasingly, we tend to use another special method, which is called the quality of life years. This is actually where you combine the life years that has been prevented from dying as a result of the intervention with the quality of life. And there are many ways to actually measure quality of life. And by having QoLIS as the outcome, we would be able to actually measure and also compare interventions which are not related to one another, but they will tell us which one is actually more cost effective, because the outcome will be similar in terms of the measurement. For example, cost per QoLIS. So the lower the cost per QoLIS would be the better in terms of the effectiveness ratio. So when we measure effectiveness, there are a number of issues that we need to look at, whether we want to include the productivity losses as a result of in our model or not. This is again need to be discussed and see how feasible you can do that. Or we want to discount the future impact, whether this need to be done or not, depending on your models and depending on your models that you're going to do, and also how familiar are you with this method. And of course, we must always use sensitivity analysis. This will help us to show the level of certainty in the cost effectiveness analysis. We can do a one-way analysis, scenario analysis, and we can also now with the software, we can do probabilistic ways of doing the sensitivity analysis, which will be demonstrated in this workshop. So probabilistic sensitivity analysis is one of the ways to actually do sensitivity analysis, and it is much easier for us to publish the paper if we do the probability sensitivity analysis. This is the study that we just completed, which is cost effectiveness analysis of influenza vaccine. We did this to actually focus on the elderly in Malaysia. What we did in the study was we measured the direct and indirect cost of managing influenza, and then we look at the cost of a new vaccine which is available in the market, which is quadrivalent vaccine. And our alternative of comparison here is actually no vaccination. So no vaccination versus quadrivalent vaccine. And the outcome of this is quality adjusted life years, where we use EQ5D to factor in the quality of life with the life years of safe as a result of having this vaccination program. And then finally, we do the sensitivity analysis using the probabilistic model. And this study, most of the data that we on costing were obtained from our hospital, from the CaseMix database, where we have, I think, quite a big number of cases of influenza. And then we combined with the information from clinical pathway to give us information on how we manage this condition if the patient were not admitted to the hospital. We use a lot of the information that are available from our database, which is from the coding of diagnosis and procedures. We take into account all these codes of diagnosis which relates to influenza. And in our costing analysis, we combine both step-down and activity-based costing in coming up with the cost in the cost model. So clinical pathway we brought in here to actually help to give more information on the pattern of practices among the experts. We measure the quality of life years, and also finally we measure the incremental cost effectiveness ratio, and we conduct the sensitivity analysis. So we have in our sample around 1,599 cases in our database, and we have out of these 407 cases for outpatient. And from this data, then we do the economic modeling to actually reflect on the actual population of the country. We have 2.7 million elderly population, 60 to 74, and another 744,000 those who are 75 years of age. And then we have the call-list loss, which actually the call-list loss as a result of non-vaccination is obtained from another study which we factored in. We put in the cost of vaccine, cost of administration, cost of GP visits. And we measure the loss of productivity if the patients or if the elderly do not take the vaccine and suffer from influenza. And the vaccine efficacy actually ranges because we have used a quadrivalent vaccine. We built in the efficacy between 59% or 0.59 for influenza A, and then for influenza B, is between 0.7 to 0.71 to 70%, depending on the age group. And then finally, we measure the health outcome. This is the cases without vaccination, and there are the cases without with vaccination. So you can see here, without vaccination, the number of people, the elderly that die from as a result of influenza is 1,887. This is reduced to 989 with the vaccination program. So next we measure the call-list that can be avoided between quadrivalent vaccine and with and without vaccination. Then we can see that the call-list gain is about 10,048, and the workday save is 79,000. We will be able to actually avoid 66,000 of influenza cases if we use the vaccination, if the patient were or the elderly were vaccinated, and we will be able to actually save nearly about 3,195 hospitalization. So finally, we look at the cost with vaccination and without vaccination. You can see without vaccination, the productivity loss is about 163 million. and this is reduced to around half of it, which 86 million, if somebody were to be vaccinated. And finally, what we did is to look at the QALYS gain. As I mentioned, the total QALYS gain with vaccination is 10,448 for that population, which gives us an incremental cost effectiveness ratio of 9,305 ringgit per QALYS. This is very much lower compared to the per capita GDP. If we are using willingness to pay based on GDP, this is lower than 1 per capita GDP, which can be classified as highly cost effective. And this is the outcome of our sensitivity analysis using the multiple one-way sensitivity analysis. And when we do the probabilistic sensitivity analysis, we can still see that the incremental cost effectiveness ratio, the minimum is 3,000, the highest is 27,000. Even if it's a cost per QALYS of 27,000, this is still less than 1 GDP. So it means that this actually falls within the quadrant 1. I think Dr. Amirah will discuss with you about the cost effectiveness plane, quadrant 1, which is give a strong indication for the government to consider this and fund this from the public funding. So in conclusion, cost analysis is an important component in economic evaluation, and we know that CA is a very powerful tool for economic evaluation. It addresses the issue of technical efficiency, and we must appreciate there are different methods of doing cost analysis. You must use the method that you are well familiar with, and also you have information and data that are suitable. Non-monetary outcome measurement is important in cost effectiveness analysis, and we are dealing a lot with cost per QALYS and incremental cost effectiveness ratio here. What are the future challenges? We need to standardize more cost effectiveness analysis technique. This has been initiative has been done for the past few years, but still we are struggling with the different methods, different ways of doing it, which is sometimes part and parcel of the real situation when we're doing research. We must encourage more cost effectiveness analysis data to be used for evidence-based policy decision, and we must actually provide an environment to encourage more cost-effective analysis in the future through multiple agency collaboration, because we need to collaborate between Ministry of Health, universities where we have the expertise, and also other partners that are involved in this. So I will stop here. Thank you so much for this brief introduction, and I look forward for you to actually interact more actively when we go into more detail of using the system. Thank you so much. Is there any questions from anyone that you want to ask us at this point of time? You can type on the chat box, please, if you feel that you don't want to speak up. Please feel free to ask anything, because I think this is a chance for us to interact, and this subject is quite technical, and probably many of you may not be able to have not been exposed to this before. Okay, I think Likke, Putri, do you want to proceed with our next topic by Amirah?
Okay, thank you, Prof. Aljunid. Rizky Salatsita has a question. Please, Mbak Rizky.
Thank you very much for the opportunity, and thank you very much for a very very great presentation from Prof. Aljunid. I'm interested in the study that you just presented, and I just seen the one of the cost variables that you've estimated. One of them is excess death, and maybe this is something new for me, as I'm also still learning about the cost effectiveness analysis and how to conduct this kind of analysis. So can you maybe explain more about why do we need to estimate the excess death, and how to estimate the excess death, and how do we benefit or how do we apply this excess death in the cost estimation or in the cost effectiveness analysis as a whole? Thank you very much. I think Prof. Aljunid is still mute.
Yeah, the term excess death is actually being sort of coined to actually compare the death as a result of with and without vaccination, and you compare with that. Even if with vaccination, the vaccines are effectiveness is between 60 to 70%. Even if somebody takes the vaccine, there are still about 30% of them might suffer from the infection. Okay, and they will die as a result of the infection. So the difference between death with those that are prevented from the by the vaccines is what we call the excess death, and this is what we try to estimate so that we will come up with a more meaningful figure when we compare the intervention versus the non-intervention group, those with vaccine and those without vaccine. So you need to understand, you need to get a figure from your population if possible. Otherwise, you say the figure that available from some other country, if you don't have yours, the mortality rates as a result of the influenza, and we discount the 70% of that from the vaccination that are prevented from dying. I hope that answers your question, Rizky.
Okay. Okay, so please, thank you for the response from Syed Aljunid. Any other questions, participants? So if there is no further, so there's a further question from Ibu Rizky. Does it also apply to the non-communicable disease?
Sure, yes. It can also be applied to non-communicable diseases as well. The only thing is that for non-communicable diseases, it takes a longer time, the longer time frame for people to die from that particular condition. For example, in our study, when we are dealing, when we were looking at HPV vaccination against papillomavirus, which is preventing people from dying as a result of cervical cancer, we use almost the same model in doing the cost effectiveness analysis. But of course, the durations for people to die from this HPV cancer cervix due to HPV would be much longer. Yes, it's applicable both in communicable as well as non-communicable diseases. The same thing, sometimes we did it for diabetes. Some of the drugs for diabetes, for example, we do that as well to look at the cost effectiveness, mortality, cost effectiveness. But we don't look at the mortality alone, but we look at the complications that affect the quality of life.
So the next question is from Mohamed as in the chat. As mentioned in the PowerPoint before, for the vaccine efficacy, can we use also vaccine effectiveness?
Yes. Why we use efficacy rather than effectiveness? The difference between efficacy and effectiveness, the efficacy is actually published from the laboratory situation, laboratory findings, whereas effectiveness is when you implement it on the ground. And then when we talk about effectiveness, many other factors might affect, and in fact, the effectiveness might be lower than the efficacy rate. But normally, vaccine effectiveness data is not readily available. So what we do actually, we use vaccine efficacy, which is most of the time publishable, because the producers normally publish this to get their drugs the vaccine being licensed. But then we actually adjust the efficacy by doing sensitivity analysis to reflect the effectiveness. So, for example, if the efficacy level goes down when it goes to the ground, when we talk about vaccine effectiveness, then the incremental cost effectiveness ratio is going to increase higher a little bit than that. So that's how we manage it. So the reason why we don't do vaccine effectiveness, or we don't use it, is because it is a scarcity of data. Vaccine efficacy is readily available, the data on the ground. Does it also apply to mental health diseases? Of course, yes. When we are talking about COLIS as the outcome, we can always apply it on the mental health situation. And I think we tend to use nowadays the measures of quality of life is EQ 5D, which can cover mental health as well. But our studies before, we use other measures for mental health. For example, we have if you talk to psychiatrists, they will tell you that there is a measurement of quality of life called HONOS, H-O-N-O-S. So we have done that before to look at cost per unit change in the HONOS scale, which can be used for mental health situation. I don't have any idea to assess the outcome. I think you can search this in the literatures. There are many ways to actually measure the outcome. The most versatile outcome in cost effectiveness analysis now is actually the cost per COLIS. COLIS is a quite well established figure. So I think if you search in the internet on the studies, most of the studies that we use is cost per COLIS. Cost per COLIS. So COLIS, quality adjusted life years, is one of the most commonly used outcome. But there are people who use, for example, life years saved, number of cases detected. So these are the other measurement of outcome that you can use, depending on your research question and depending on your research focus.
Okay. Thank you, Professor Aljunid. So we still have 2 more minutes for last questions. So I guess, thank you, Professor Aljunid.
Welcome.
Yep, I think we now can proceed to the next session. So our next speaker is Dr. Amirah Azzeri. She will share a topic on basic health economic modeling and its application using TreeAge software. Dr. Amirah Azzeri, please welcome to the conference.
Thank you so much, Doctor. So let me share my screen first.
Okay. Yeah. Hello, Dr. Amirah Azzeri.
Yes. Can
Yeah.
you hear me?
Perhaps can you speak a bit louder, please?
Okay. How about now? Can you hear me now? Better?
Yeah, that's better.
Okay.
Sorry, sorry.
Okay. Alright. So can you see my slide now?
Yes, the PowerPoint looks clear, but could you please speak a bit louder, please, Dr. Amirah?
Okay, sure. So Assalamualaikum and a very good morning to all. First of all, I would like to say thank you very much to the organizer for inviting us to conduct this workshop, and also special thank to Prof. Syed for giving us this opportunity to be the trainers for this pre-conference workshop. My name is Amirah. I'm from USIM, University Sains Islam Malaysia. And my topic today is on basic health economic modeling and its application using TreeAge software. All right. So this is the outline of my presentation. I will begin with some introduction about the model, and then I will talk on the economic evaluation model, stages in economic evaluation, as well as developing cost effectiveness analysis model in TreeAge. So I understand that many of the participants here, maybe everyone is excited to do the modeling in the TreeAge software. But I believe that perhaps we can go through some of the theory first, so that later on when we conduct the modeling or the model exercise in the software, it's help us, or it makes us easy to interpret and to understand the outcome of the model. Okay. So what is model actually? When we talk about model, economic model, disease model, so what is model actually? So models are a representation of a particular thing, idea, scenario, situation, or condition. That means we try to represent something which is in real life, perhaps scenario or condition, and we wanted to simplify it. We give an abstraction of that particular condition. So let me give example of COVID. When COVID came and hit us, right, we are not sure what will happen to the patient. Either the patient will go to the chronic lung disease or influenza-like illness, so on and so forth. So based on what we have, our background knowledge, we try to represent what could be the pathway, the possible outcome of our patients. So thus, models describe our beliefs about how the world functions, how the disease progressed, how the, in fact, not only in healthcare setting, in business setting, for example, what is the possible revenue, what is the future surplus, for example, that we will experience based on certain conditions. So models represent the complex world in the simplest form. So this is one of important thing that I would like to highlight here. So when we conduct any model, we wanted to represent it in a simplest form because our life is complex, right? So we do not want to recreate the complexity, but in fact we try to simplify things because we need to get the output to help us, to facilitate us in decision making. So again, important note from this workshop is that model is a simplification of the real world. We will try to simplify things, but we have to ensure that all the important components, elements should be incorporated in the model. And we have to put some assumption or approximations about how the system works, because we are human, right? We do not know what can happen in the future. So based on pre-existing knowledge, based on our reading, based on our observation, perhaps we can put some assumption on how things are going to work, and also things to incorporate in our model. So because of that, one professor, Professor George Box, once said, essentially all models are wrong because we are human, we are just human, right? Even though we try to do a predictive model, a forecast, a projection, but somehow there are things that is beyond our control. For example, say in 2019, perhaps if I have a business and I projected that based on my sellings, my products, I can get such income. But when the COVID-19 hit us, so many of the sectors were affected. So those are the things that is beyond our control, and that is why these professors said that all models are wrong, but some are useful because it has been proven that many predictive model, forecasting model, projection model help us to guide decision making, especially in health economics, when we wanted to allocate adequate resources. So we do projection to ensure that our healthcare system delivery is efficient, is sustainable, so on and so forth. All right. So I give you one example. So for example, we wanted to study on a car, right? So we wanted to have an extra features of the car. For example, we wanted to put some technology for the mirror or for the wheels, for example. So if we are going to test in the car itself, so we do not need a model, right? We can just test it in a real car. But then again, because if we test it in a car, perhaps there are some limitation. We have to wait for the outcome. Perhaps, for example, it's too big. For example, it's difficult for us to conduct the experiment in the actual car. So we come out with a model. So again, like we have discussed before, model should be simple. So perhaps if you want to test the wheel of the car, for example, you just have to make a simple structure of the car. So this picture can represent the car, right? You have a tank, you have a battery, the wheels, the body. So it should represent the car. But then again, this simple thing about model is subjective. Some modelers perhaps they like to make it more similar to the actual thing. So perhaps they will come up with another model. So they will have like a clutch here, a battery charger, inverter, so on and so forth. So if I may suggest for you to conceptualize your model, to have the structure of your model, it goes back to your research questions, to your research objective. Like Prof. Syed said, right? You must have your plan, what you are going to do, what research question that you want to answer, so that you can represent the actual things in a model appropriately. Okay. All right. So one of the challenge thing about doing a model is that it is not to produce the most comprehensive descriptive model, but to produce the simplest possible model that incorporate the major features of the phenomenon of interest. So, like we have said before, if we are going to design a model that is exactly the same as the actual thing, so we better to conduct the analysis of the experiment with the actual thing itself, right? So if you want to do a model, so we have to produce the simple, as simple as possible, but to incorporate all the major components, features, elements to represent the actual thing. Perhaps people will ask, so why do we need a model? We can straight away do it in the actual things, right? For example, if we want to see what will happen in the COVID cases, we don't want to see the predictive analysis, the projection number of cases, for example. We just wait and see. Sometimes it's difficult because we need to make a decision fast. So because we want to make a decision fast, so we need something to simulate our thinking. So that's why we conduct a model. So again, doing a model, the model itself, it's not an exact recreation of the original system, right? Because again, if we wanted to create exactly the same, right? So it will actually timely for, it will give extra time for us to develop a complex model. But at the end of the day, it's not very helpful for future decision making, so on and so forth. All right, so after we have been introduced with what the model is all about, perhaps we would like to know what are the advantages of doing model, why we are so interested in doing a model. So model help us communicate, right? For example, during the peak of the COVID-19, when we can see the projected number of cases, right? We project that by certain month, our hospital, our ICU will be fully equipped, for example. So in that, before that happened, so we can manage our resources adequately. For example, we send our doctors from other areas, less number of cases to Klang Valley, for example, to help to manage the disease, the cases in Klang Valley, in the area which is most affected, for example. So it helps us to communicate and make decision. And then models allow us to clarify and test our understanding. Sometimes when we conduct a model, we thought that the model, that output will turn out to be like this. For example, when we conduct a model about hepatitis C treatment, so we said after they receive treatment, it's either cured or not cured, for example. But actually, after we have done the model, we saw that this new treatment is, the flow is not like that. So the patient can be cured or reinfected or not cured at all, for example. So by doing a model, actually we are learning too, because it helps us to clarify things. We can understand the disease progression better. So yeah, so it helps us to learn a lot from our own model actually. And then model creates credibility and accountability. So especially when we wanted to talk, to present our findings with decision makers, politicians. So we need to give them an informed or evidence-based decision. They wanted to see the magnitude. They wanted to see something that is objective, right? They do not want to see something that is abstract. Even though our model is abstract, but the output, we can present it in a form that is very, in form of numbers or figures that they can easily understand. So it gives us some credibility to deliver the message properly. And models help you to organize your thoughts, as what being shared before, like in COVID, right? It helps us to allocate adequate resources, budget, so on and so forth. And it simplify and solve problems. If, for example, we have two options, we do not know what to choose. So by conducting an economic evaluation model, so it guides us to choose which alternative is better for our population. So this is a repetition. What is model? So model is an abstract. Okay, it's not the actual thing. It's an abstract representation of an existing condition, problem, situation, scenario, system, so on and so forth. So because it is an abstract, model can be presented in a form of picture. So if we can still remember our butterfly life cycle, right? We have from caterpillar and then stay in a cocoon, become a butterfly. So that picture is also one of a type of model, because we can see what will happen next. So that is how you can present your model. In terms of graph, I think this is common, right? When we can see whether our KPI, for example, our key performance index is improving or not over a time. So you can see, you can present it in a form of bar graphs. And also chart, like line chart, right? For example, if we have, we wanted to see our environmental condition, whether our particulate matter to detect the haze, right? Whether it's increasing or decreasing. So we can present it in a form of chart. But then again, the first three presentations, picture, graph, chart, they are usually descriptive. That means you have the data, you have the model, you try to describe the model. So you present it in a form of picture, graph, and chart. in economics or in health economics, in many, for example, healthcare settings, sometimes we need some touch of analytic model, right? We need the model to be able to analyze something because we wanted to come up with a decision. So most of the time, we will choose this mathematical model. Yeah. So as the name implies, mathematics, right? It's mathematical models. That means it has numbers as well as symbols. So when you combine it, it becomes equation, and it can be presented as algebraic formula. So for example, if we remember our y is equal to mx plus c, we usually see that formula in our mathematics in school, perhaps when we learn about regression, right? Linear regression. So we use that formula equation too. So that is also one of example for mathematical model. So as you, for example, y is equal to mx plus c, right? As you increase the x, the y will be increased. So those are model. It helps you to predict things, right? To forecast things. For your regression analysis, for example, you wanted to see the incidence of cancer. So you have, if you conduct multiple regression analysis, you can see that incidence of cancer is equals to the odds of being male 2.5 plus the odds of obesity 4.5 plus the odds of Malay 7, for example. So those are actually model. It helps us to predict, right? So two example is a mathematical model. So in mathematical model, actually under the mathematical model, there are many types of model, yeah, that involve these numbers, formulas, equations, so on and so forth. So in health economics, the commonest types of model is the decision analysis model. Not really the commonest, but the simplest type of model is the decision analysis model. In addition to this, we also have Markov models, Monte Carlo model, and other actually like survival analysis models, so on and so forth. But for economic evaluation, we usually do these three models. And of these three models, the simplest one is the decision analysis model. This one. So decision analysis model is also known as decision tree. Yeah. Why? I think you can clearly see from here, right? Because it looks like a tree. It has a trunk here. It has branches and many branches from this particular one. So it looks like a tree. That's why we call it as decision tree. Okay. So what is decision analysis model or decision tree? So a decision model is a structure representation of a decision process that allow a person to perform a decision analysis. So that means it's a process altogether. It started from here and here, then it's a process. Okay. So it's a mathematical representation. That means in that particular structure, you will have numbers, you will have equation, you will have formula of a series of possible events that flow from a set of alternative options being evaluated. So if you can see back the previous slide, so you have options, right? You have two options. And flow, what will happen if you choose this? What will happen? Either this one or this pathway. Similarly, if you choose this, what will happen? This pathway or this pathway. So it's a process, it's a flow when you compare alternatives. So that's why Prof. Syed has mentioned earlier, you need more than one intervention because you need to compare, right? Economic evaluation is about comparison. So you need to compare between several interventions, at least two interventions. Okay. So in a decision tree, again, at least two alternatives. So you must have likelihood of each event in terms of probability. So because you have the structure like this, right? So when you choose treatment A, So the patient can be in this pathway, the cured pathway or not cured pathway. So there must be a probability, some numbers of how many percentage, what is the probability of people can go to this pathway. What are the remaining probabilities for this pathway? So you must incorporate some numeric values in this structure to run the model. And then each event has associated values and outcomes. So with every pathway that the model has, so it must have the input as well as the output. So in economics, in health economics, the input is cost. So you can have the cost here, and if cured, perhaps the follow-up cost, so cost here as well as the outcome. Okay, all right. So decision analysis model or decision tree, which we are going to conduct this in our hands-on exercise later on, is used for one-off decision. That means it starts here, it ends here. So it cannot like be, if it's go here, right, major complication, for example, then you can move to the next, the other end. That means you can move also to the no major complication. Or halfway you have received this, halfway you want to change your treatment option. So there is no such thing in decision tree. It's a one-way process. So that means it has to start here and ends here. It's a one-way process, okay, or flows. So because of its characteristic like this, so it is used for acute cases. For example, influenza, right? Like Syed said. So we can have the vaccine, right? Vaccine, no vaccine, for example. So whether the patient has influenza, no influenza, has influenza, no influenza. So that's how the process goes. And then it is for once only diseases. That means acute disease, usually without the recurrence, and short-term diagnostic or screening decision. That means if you wanted to study on one diagnostic test or screening test that is short-term. I mean, you don't have to like follow up the patient, change the treatment. So it's a straightforward thing. So it is suitable for decision analysis model or decision tree. So these are two examples of decision analysis model. Okay, so for example, you wanted to look at a treatment for hip fracture. So either you can choose prosthetic replacement or internal fixation. So based on this, you just wanted to see whether the patient has major complications or no complication, no major complications. Similarly with the other treatment option. Okay. So in another example, we wanted to look at this infection, whereby you can treat the patient with these antibiotics, vancomycin, or another antibiotics, fidazomicin. So whether the treatment will be failed or initial cure, and then what will happen next? So these are the possible outcome of these two interventions. Okay. So again, to highlight, there are limitations, right? Because decision analysis model is the simplest model of all. So there are limitations. It is less suitable for longer term outcome. For example, you wanted to look at liver cancer. So it has a very long course, right? From liver cancer, and then you can be treated, and recurrent can happen, and then metastasize, so on and so forth. So there are many outcomes for that condition, so it is not suitable for you to conduct decision analysis model. And again, it is difficult to handle recurrent because it is one way, right? If you have recurrent, that means either binary, yes recurrent, no recurrent. So it doesn't matter whether that recurrent will go to less severe or more severe, so they cannot handle that in decision analysis model. Okay, all right. So we have learned about decision analysis model or decision tree. So these are the stages on how to conduct decision analysis model. This is the theory part first. Later we will do exactly the same with our TreeAge software. Okay. First, you have to conceptualize your model. You must have some idea in your mind based on your reading, based on the published literatures, perhaps based on discussion with the experts on how you are going to conceptualize the model. Okay, for example, if you wanted to compare treatment from treatment for liver cancer, so either liver resection or liver transplant, for example. But if you're not sure what are the outcome for liver transplant, so it's hard for you to conceptualize your model, right? Back in 2015, when I did my study on the hepatitis C disease, so we have liver cancer as one of the disease stage of the sequelae of the hepatitis C. So at that time, liver transplant was not very common in Malaysia. So it hard for us to forecast what is the possible outcome with the liver transplant. So in that case, so we didn't conduct the analysis for liver transplant. So that's why you must have an idea before you conduct or before you make the structure of your model. Okay. So for example, if you are clear with hip fracture, this treatment option, this is the outcome of interest. So you are clear with it. So it's easy for you to conceptualize and to put it in the decision tree structure. Yeah. So second stage is to identify the evidence. When you have draw your structure, you must identify the evidence. Again, for economics, you must have the cost, you must have the outcome. So you need to identify where can you get all these evidences. So once you have obtained the evidence, so you have to put it or plug the evidence in the model. So when you plug the data in the model, this is when you populate the model. So you tell the model, these are the data, please run it for me. So that's how you populate the model. And then you finally analyze the model. So because I believe many of us here are health economists or people who would like to study on health economics. So our outcome of interest is usually the ICER. So you can interpret the outcome, the ICER that you obtain from your model. Then you validate the model and explore the uncertainty as being mentioned earlier. All right. So perhaps we have talked about decision analysis model or decision tree model, right? So we cannot forget our another type of model, which is Markov model. Markov model is actually very common in health economics evaluation too, because as we said before, there are limitations in decision tree, right? It is suitable for acute cases, one-off decision, short term, so on and so forth. But in real life, in our disease that we have learned, right, there are many diseases that is chronic in nature, that has many circumstances when you have the disease, many outcome of the disease. So in that particular condition, the chronic disease with many outcome, it's hard for us to structure it, to conceptualize it with a decision tree. So that's why we have to conduct a Markov model. So Markov model is actually to complement the decision tree. If we cannot proceed with decision tree, so we have other option, which is Markov model. So if you can see here, this is the structure of Markov model. So it's very complex, right? Compared to our simple one flow decision tree. So you can imagine this thing, you have to replicate it with the options that you have. For example, you have like treatment A, treatment B, treatment C. So all of this structure will be duplicate in all the arm of the treatment options. So that's how complex Markov model can be. But again, there are reason why modelers come out with the theory of Markov. Yeah. So for example, this oval things is called disease health state or Markov health state. So when you are in this particular disease state, you can progress to either this stage. For example, this is disease free. You can go to contralateral tumor, or you can also go to disease free plus osteoporosis, or you can just stay forever in this disease free, for example. So you have many pathways from one health state or one Markov state here, right? All right. So Markov model use disease state as we mentioned. So this here we have 7 disease states to represent all the possible consequences of an intervention of interest. So you can imagine if you have treatment A and treatment B, both treatments will have these possible consequences. Okay, so the disease state are mutually exclusive and exhaustive. So each individual represented in the model can be in one and only one disease state at any given time. So again, Markov also has limitation in which that if you are in this disease state, you cannot be in another disease state, right? Which is sometimes in our clinical setting, right, we can see like our patients, but we are not sure whether, for example, whether COVID 3E or 3B, we are not sure. It can be both, right, based on their parameters and so on. But for Markov model, you have to think whether the patient will be here or here, cannot be at 2 disease health state at one time. Okay. All right. So individual can move between disease health state as their condition change. So again, they can move here, they can move here, they can stay in this disease health state, so on and so forth. So the time in this, the time spent in this disease health state, we call it cycle. So that's why if you read the literature on cost effectiveness analysis that conduct Markov model, you can see that sometimes they said that the cycle length of the disease state is 1 year or 6 months, for example. So it depends on the disease that you wanted to study. So for example, if for COVID, right, if you say it's 1 year, it might not be true because the progression is faster than a year, right? When, for example, in unvaccinated people from less severe, from asymptomatic to straight away to stage 4, stage 5 is faster. So 1 year life length perhaps is not suitable for COVID. So again, it depends on the disease that you want to study. All right. So when you move from one disease state to another, it's called a transition probability. Remember, in the decision tree, you have a probability, right, of from one pathway to another. But in Markov, we have transition probability. That means you can move from one disease health state to another. And again, for each transition, it will be associated with a cost and the outcome. Okay. So you can imagine the data that you have to collect before you populate the model. Before you conduct this model, you have to get a lot of data. For example, transition probability for each pathway, cost for each disease state, as well as the outcome before you can conduct the model. So again, just now we have seen that Markov has one limitation in which people in one, they cannot stay in more than one disease state at a time, right? So like if you are here, you are here until you complete your length of the cycle, then only you can decide to move here, or to stay again for another year, for example. So that is one limitation of Markov. Another limitation of Markov is that it does not have memory. So they can't remember what happened in the past. So for example, if you have moved to this disease state, so this model, they don't capture the data whether you are coming from this health state, or you are coming from this health state, or you are coming from this health state. So once you are in this particular health state, the contralateral tumor, regardless where you come from, the cause and the outcome will be the same. So that's how Markov interprets it. Yeah. So once from contralateral tumor, you move to this local regional recurrence, right? So here is cause and outcome. So cause and outcome will be the same, whether you come from contralateral tumor, or you come from disease-free plus osteoporosis, or you come from here. So it doesn't have memory. It does not remember what happened in the past. So because of this limitation, modeler come up with another type of model to complement Markov model. So that is what we call as Monte Carlo. So unlike Markov, Monte Carlo has the ability to remember what happened in the past. So you can imagine in Monte Carlo, you will have a lot more of data. You have like cost for contralateral tumor if the patient come from disease-free health state, cost in contralateral tumor if the patient come from disease-free and osteoporosis, so on and so forth, as well as the outcome. So the data is more intense for you to collect for Monte Carlo. So I believe that this modeling exercise is evolving, right? So when we found some limitation, we try to complement the previous one. So it's like a process for modeler 2. When we learn that decision tree has limitation, they come up with an idea, a theory of Markov. When Markov is inadequate, they have Monte Carlo. Perhaps after this, they will have other options to minimize the limitation of the previous models. Okay. All right. So that's about the model in general. Next, we are going to learn about economic evaluation model or health economic evaluation model. I believe that this is a repetition from what Prof. Syed has presented before, but perhaps it's a revision for us, and I hope everyone still with me. So before we proceed, anyone would like to ask any question? Or if not, we can proceed first, and then we can see at the end of the presentation. You can ask question, okay? But if you have any question, just ask. You can simply ask in the chat box or raise your hand, okay? Okay, so just now we have learned about model. So this the theory part about the model that we have learned can be applied in healthcare setting, in business setting, for example, in fact, in environmental setting, right? So I remembered a friend of mine, he studied on the environmental health, whereby he wanted to forecast when is the next haze in Malaysia. So in order for him to forecast that, to predict that, he also used model, right? And mathematical model. Okay, so that is model in general. Now we are going to see the economic evaluation model. So again, I remembered my professor once said, in health economics, it always takes two to tango. You must have these two options. You must have the cost and the outcome. Similarly, if we remember our case mix, right? You must have two. You must have ICD 10 and ICD 9 CM. So that's how it takes two to tango happen in health economics. So we need our cost or inputs as well as the outcome and benefit. And then we need to have alternative treatments or the comparators that we would like to see in our economic evaluation. Yeah. So again, economic evaluation model is one of the tools available to help choose wisely from a range of alternatives and implement efficient resources. So it helps us, it guides us to decide which one to choose when we have several alternatives. Why do we need to choose? Why can't we do all? Why can't we do both? Because again, remember in our health economic textbooks, the first statement is always resources are always scarce, right? We have limitation in our budget, in our personnel, so that's why we need to choose. Okay. All right. So this is actually the same as Prof. Syed has presented. This is the types of economic evaluation. Again, it can be further divided into full economic evaluation or partial economic evaluation. So full economic evaluation include cost effectiveness analysis, cost utility analysis, cost benefit analysis, while partial is called cost minimization analysis. So why is it full? Why is it partial? So it's full because it estimate or it has data on cost and effect, and you conduct the comparison simultaneously. That means you look at the cost, you look at the outcome, then you compare. So that makes it full, right? But if it's partial, that means you just look at the cost, for example. See the effect here? The effects are not measured. So because the effects are not measured, it's not complete. You can see that's why we can't call it full economic evaluation. It's partial economic evaluation. But then again, even though it's partial, it is still useful because sometimes we wanted to know what are the costs, right, to manage certain disease, for certain intervention and so on. So um, we cannot say that cost minimization is not useful. It is useful. Again, it is depend on our aim, what we wanted to show actually to the policymakers or to decision makers. Just the cost. You wanted to compare the cost and outcome, so on and so forth. Okay. So just to highlight, for today's workshop, we are going to focus more on CEA, cost effectiveness analysis, and CUA, cost utility analysis. So both CEA and CUA has a similar structure, yeah, in which that you will calculate the cost and the effect. The only difference of CEA and CUA is on the effect or the outcomes or the output, whatever you want to call it, okay? For CEA, the outcome is in terms of natural units. You can present the outcome as life years gain or number of cases detected, death averted, life expectancy, so on and so forth. But for CUA, it's utility, right? So the outcome is utility, which you can transform it into qualis as we learned before, or dalis. Okay, but having said that, when you look at the literature later on, sometimes the authors, they conduct actually the outcome is actually utility, but they call it in their title as CEA, cost effectiveness analysis. So I would suggest not to focus on the title so much. You have to read the content, then you will actually understand whether the author really want to conduct CEA or CUA. Okay. Okay. So just now we have learned about full partial economic evaluation, right? So actually just wanted to highlight another types of economic evaluation which is not very common, but it is useful actually, and it's actually similar to cost minimization analysis. But it has disparate outcomes. So what do you mean by disparate outcome? That means for this, you only will talk about the cost, but for cost analysis or cost minimization analysis, you will have one type of cost only. For example, you wanted to calculate direct medical cost from patient's perspective, right? So you have that cost only. But for cost consequent analysis, you have several types of costs depending on your research question. For example, you have you wanted to present the cost in terms of lifespan of first restoration, and this is the outcome. You wanted to also present the cost, patient's lifetime. So imagine the patient can live for 100 years. So this will be the cost and the outcome. So it has disparate report that you can generate from cost consequent analysis. Okay. Again, this is also partial because there is no comparison, right? It's like describe one intervention in terms of the cost and the outcome. All right. So as we have mentioned before, this is the type of economic evaluation that we would like to focus. It's CEA or CUA. Okay. Again, to repeat, you must at least have two alternatives. Okay. Alternative 1, alternative 2. It's a process from one end to another end, and for each pathway you must have the cost as well as the outcome. Yeah. So remember, in health economy, it takes two to tango. You must have the cost and the outcome. Right. So just to share with everyone here, this is part of a study conducted before with my team, whereby we look at the cost effectiveness analysis of hepatitis C treatment, in which we compare the new treatment, the direct acting antiviral drug, with the previous or the traditional treatment, which is interferon. Yeah, PEG interferon. And this one is Haveni, ledipasvir plus sofosbuvir. So we wanted to compare what will happen to our hepatitis C patients if we treat them with either of these two treatments. So so the outcome of interest that we are looking at it, because we wanted to see for for newly diagnosed hepatitis C patients at that time. So we just wanted to see whether they are cured or not cured, right? So this is an example of a study that we have conducted before. Okay. Again, so when we have learned about the structure, about the details, so what is actually the role of modeling in economic evaluation, right? I remember when I first started to study on health economics, I was struggle to understand why do we need a model. We can just do the mathematics itself, right? We can just calculate it manually, in fact with perhaps with our calculator, with the Excel, but actually with modeling you can project more, right? Perhaps you can calculate the cost, the outcome, the ISA at one point with your calculator and Excel, but we wanted to see, for example, lifetime cost until the patient die. What will be the cost? So that's how modeling help us to have projection of the cost, prediction of the cost, right? So we can extrapolate the cost and effectiveness. And then it reflects appropriate evidence and relevant options. So it helps us to inform our decision maker. This is the appropriate things to do based on what resources that we have, for example. And then it linked the intermediate clinical endpoint to the final outcome. Remember, just now Prof. Syed mentioned about intermediate, right? So intermediate endpoint to final outcome, it linked. Because it's a process, it's a flow. So it informs resource allocation decision in the absence of hard data. Sometimes we don't have the data. Before we conduct the cost effectiveness of hepatitis C treatment, we don't have any idea whether it's worth to give our patient with direct acting antiviral or just proceed with the PEG interferon. We don't have any idea. So by doing that, it gives us some idea whether it's worth or not. So CEA, cost effectiveness analysis, it gives us information whether it worth or not to choose that intervention. So worth or not, it depends on the ISA values. Okay, and then it's make head-to-head comparison of the alternatives that we are going to compare. Okay. All right. So other than health economics in specific, so perhaps many of us here are also public health doctors, right? We study public health. So we wanted to know, is it so important, health economics from public health point of view? So it is, because we will try our best to maximize the outcome, the health outcome in our case, with very minimal cost. So that is called efficient, right? Because sometimes we don't have enough budget, we don't have enough resources, but we will try our best to maximize the outcome. So that is what efficiency all about in public health point of view. And because of the scarcity of the resources, it's hard for us to make the decision. So that's why we conduct economic evaluation to help us to decide, to choose wisely. And then again, when we decide, that means, for example, when we decided to choose the direct acting antiviral, for example, or perhaps when we decided to vaccinate our people with COVID-19 vaccine for free of charge, for example. So of course, the government would like to know, based on what they have spent, what is the return of investment that they will receive. So with economic evaluation, it will also help us to come out with return of investment analysis, perhaps budget impacts analysis, and other relevant or related analysis. Okay. So before we do the economic evaluation in our software, so perhaps we will go through this briefly on the stages of economic evaluation. So again, the first one is to decide your study questions. So don't be hurry. Even though sometimes we are very excited to conduct, right? So we must ensure that we have knowledge about it, we have information about it. So don't rush. So try to ask yourself first, either is it very important for you now to conduct the economic evaluation or not? So what is the problem? Is this problem important? So do you really want to to see this? Anyone interest with your findings? So you must ask yourself first, right? It's like before you start your PhD, right? You must choose your topic wisely. And then when you have landed with one topic, for example, you wanted to study about COVID-19 vaccine, either Pfizer or Moderna, for example. So you must choose the alternative options properly. Whether Moderna vaccine, for example, is it available in your setting? Is it easy for you to get data on it? So you must choose your alternative options properly. And then you have to know who are you going to present this. If you're going to present this to the company, insurance company, for example, so you must tweak your presentation so that they will understand it, perhaps less medical jargon, less technical terms, so that they will understand the output. If you wanted to present this to your Prime Minister, for example, or your Ministry of Health, so you must choose appropriate output to show to them. Perhaps they are not very interested in the structure of the model, but they wanted to know the output and the uncertainties of what can happen. Okay, and then you must choose your perspective. That means whether you want to conduct it from the health insurance company perspective, or provider's perspective, or hospital perspective, and define your time frame. So your model, you have to tell the audience, this model, this prediction only predict until the age of 10, for example, if you do, for example, neonates vaccination. So this model will capture data or will represent the flu until the kid is 10 years old only, not until they have in teenagers or adults, so on and so forth. Okay. All right. So after you have decided on that, you are clear on that, you need to see your cost and the outcome. Okay. I think this one also Prof. Syed have walked through us, right? Have discussed with us. You need to know what cost that you would like to use in your model. Either direct cost only or indirect cost only, or perhaps you would also want to explore other types of costs, right? So you must decide first, because if you have direct cost for one treatment option, you must also have the same direct, not the same, the direct cost also for the other option. You cannot have one in treatment A, you put direct cost. For treatment B, you put direct cost and indirect cost. So it's not the same, right? So it's not comparable. So model can't be like that. It has to be comparable. And then you choose your cost category, whether it's reflect the program, patient's perspective or hospital. Similarly, your organizational level, what you are trying to say. If the cost is 7,000 rupiah, for example. So what does the 7 rupiah means? Is it the cost that will be incurred by the patient or by the hospital? So on and so forth. And again, the cost components that you would like to include. Is it include the training of the healthcare workers, or just the event itself, or perhaps the administration? So you have to decide. Again, horizon. Horizon means the cost reflect for a year, lifetime cost, or for up until 10 years, for example. So it depends on your horizon. And you have to do adjustment of cost. So there are many adjustments that you have to consider. For example, if we conduct a study and we cannot find any cost data from our local country, right? We need to borrow data from our, say, developed country, from US. So you have to ensure that the unit, that means USD and Ringgit Malaysia, or USD and Rupiah. So you have to convert the currency properly. Okay, that is one example of the adjustment that you have to do. And also the outcome measures. You have to decide, whether the outcome is in terms of utility, qualis, or life expectancy, so on and so forth. Okay. All right. The next step is adjustment for timing. Okay, this is also interesting because you are dealing with economics, right? So in economics, we have one term that we call as discounting. So what is discounting? So as a normal human, I believe that many of us prefer to have the benefit now and pay later, right? For example, if we are going to buy a car, we wanted to have the car now, but we want to pay it later. We wanted to have the house now, we wanted to pay it later. So because of that preference, which we call as time preference, that is why economists come out with the theory of discounting or discount rate. So this discounting or discount rate allow for differential timing of cost and benefit between programs in which all future cost and benefit should be stated in terms of their present value using discount rate. So there will be a formula that you have to plug in to reflect the cost properly. For example, you will incur cost in year 1, year 2, year 3. For example, year 1 is 7 rupiah. But in year 2, even though it's 7 rupiah, but the value might not be the same as 7 rupiah in year 1, right? So because of that, you have to put some adjustment. So you have to, there is a formula for it. Perhaps for this workshop, I will not share with you the formula, but it's available if you can Google it. So you have to put all the formulas to reflect the cost properly because of the time preference. Yeah, because normal human, we always want to pay later and get the benefit now. So because of that, future cost is given less weight. So again, 7 rupiah now has a higher weight compared to 7 rupiah in 10 years time, for example, right? So that's why we have to use the formula. And another thing that we have to adjust is the amortization, right? Like Prof. Syed has said. For example, when we wanted to build a hospital, so we have to bear the cost of building now. But the hospital will last for several years, right? So we have to put the yearly cost appropriately because we have to consider the depreciation of the asset. So usually amortization will be applied to any asset or capital in which capital costs represent an investment at the start up in an asset which is used and depreciated over time. So for example, car, right? Perhaps when we buy a car, in economists, they usually said that for transport, the depreciation time is 5 years or 3 to 5 years. So that means after 3 years, actually that is perhaps, if I can say it, there is no value, not so much value of the car compared to the first year because it's depreciated over time. Okay, all right. So that's what you have to do. All right. And last but not least is the uncertainty. Again, this is important because uncertainty is a process of assessing the robustness of an economic evaluation. Yeah. In our life, if we can relate it in our life, there is no such thing as fixed value, right? We always have a range. For example, if people ask me, okay, how much would you like to pay for Paxlovid if you are infected with COVID-19? So it's hard for me to give like 10 ringgit. For example, it's quite hard. So perhaps it's easy for me to say that, oh, I think I am able to pay from 5 ringgit until 15 ringgit. So it's a range. So life is complex to begin with. It's hard for us to give a fixed value. So it's always in a form of range, right? So because of that, we can put that particular range in a model to do this uncertainty analysis. So there are many ways, many methods to do uncertainty analysis. First and foremost, not all parameters can have this uncertainty. Perhaps if it's a fixed value, for example, if let's say the cost of the vaccine throughout the world is the same, so it's a fixed value, so you don't have to put a range for that. But for other parameters that you are very not sure, it has the minimum of this, maximum of this, so those are the parameters that you have to consider in your uncertainty analysis. All right, so these are the methods that you can use. You have deterministic, probabilistic, scenario analysis, threshold analysis, so on and so forth. But for today's workshop, we will concentrate on the deterministic, and I will also introduce you to the probabilistic. Okay, so this is the deterministic sensitivity analysis. So again, for example, when you first populate the model, right, you have this value. Say that this is a study that compare between the current treatment for influenza compared to zanamivir, the new antiviral for influenza, for example. So you have the mean value here. That means the probability, right? The incidence of getting complications when you treat your patient with the standard care or with zanamivir or death, for example. So you have the mean value here. For you to conduct sensitivity analysis, again, you have to put a range for appropriate parameters. So perhaps it's not 0.4 actually, because in real life, you have like adults, you have comorbids. When you consider other factors, so it's actually range from 0.2 to 0.6, for example. So this range, when you plug in the model in your software, it will give you this diagram, which we call as tornado diagram. And tornado diagram will have these colors, blue and red, usually, if you are using TreeAge. So then there are ways to interpret it. So Dr. Hafiz, the third speaker, will teach you on how to interpret this tornado diagram. Okay. So other than deterministic sensitivity analysis, we have probabilistic sensitivity analysis. So in probabilistic sensitivity analysis, you need to gather more input for your model, because not only the range, you will also need the distribution, yeah, for that particular parameters. So for example, you know that the mean value for a complication with a standard care arm is 0.4, but it ranges from 0.2 to 0.6. But you must tell your software what is the distribution, so that the software can use that distribution to run, to do the analysis. So what do you mean by distribution? If you remember in statistics, right? These are the three commonest, the three common distribution that we can have. So either it's beta or gamma or normal distribution, our bell-shaped graph. So for beta, that means it bound from 0 to 1. So you cannot have values less than 0. You cannot have value more than 1. Okay? There is no such thing as 1.1 in beta distribution. There is no such thing as negative 2.3 in beta. So there is no such thing. So it has to be from 0 to 1. So usually, this beta distribution will be used for our probabilities, right? Because our probabilities usually is like percentage, right? From 0 to 100% or 0 to 1, right? Similarly, with our utility values, if you are familiar with health state utility values, right? It ranges from 0 to 1. So 1 is the perfect health state, 0 is the state that is similar to death. So if I ask you, what is your health state utility value today? Perhaps for me, I can say, mine is 0.9, because I am happy to deliver this workshop today. So that is utility value. So it ranges from 0 to 1. So for probability and utility, usually you will have beta distribution. For gamma, it ranges from 0 until infinity. It does not have a maximum value. Okay, so usually you can use it for cost, right? Because the cost can be anything, right? Can be 10,000, 8,000, 500,000, so on and so forth. But you can have negative cost, right? So that's how gamma distribution looks like. Okay, and for normal distribution, it's like our bell-shaped curve. That means perhaps if you want to also include age, for example, as one of your parameters in your model. So you can tell the software, look, age in this model is normally distributed. or BMI or weight, height, blood pressure. So those the continuous data you can, if it's normally distributed, you can tell the software that this is normal distribution. Okay. All right. So that's the end of the theory part for model. So perhaps before we go to the hands-on, anyone has any question that would like to ask? So there is one question I can see here. I would like to ask that, is it possible to conduct CEA in nursing field? For instance, using non-pharmacologic intervention to reduce pain by using distraction technique such as deep breathing, guided imaging. I doubt about how to get the cost of this intervention. Oh, okay. So if I can answer this. Perhaps if it's not complete, Dr. Hafiz and Prof. Syed can help me. So for CEA in nursing field, it is possible. Yes, you can compare pharmacologic intervention. For example, you want to compare pain management, right? For deep breathing and guided imaging. Or I remember last 3 weeks, one of the rehab professors came to visit our department and said that he wanted to compare pain management of knee osteoarthritis by using physiotherapy versus intervention pain management. So it is possible to do that. But you have to know the flow. That means you need to get some idea what is the process, what is the outcome gonna be. And then to get the cost, there are many ways actually to get the cost, as Prof. Syed has shared with us, right? If you have case mix tariff, you can use your case mix tariff. Or if you want to do primary data collection, you can collect data based on your hospital finance report. Or if it's hard to get the data, you can complement the data with published study, be it local studies or international studies. But then again, you have to do some adjustment to the cost. Yeah, so that would be my response. Any further comment from Prof or other people? I hope that's answer your question.
Yeah. Thank you, Dr. Amirah, for the response. So we have some questions. First from Putri Listiani, and it has been addressed by Professor Syed. So and here we have Ibu Dia Ibu Spandari raise her hand. Please, Ibu Dia.
Yeah, thank you, Bu Likke. Thank you, Dr. Amirah. Can you hear my voice? Oh, yeah. Thank you, Dr. Amirah. Your presentation is so clear, but I still have one question for you that you already mentioned in your previous presentation, that model can be differ due to a variety of components we put into the models. So starting from a simple one until a more complicated one. So in which way we know that the models that we design is representative enough to the real life? Thank you.
All right, so thank you, Ibu, for the question. Okay, to answer that question, actually the development of model itself is, I would say, it's not, we don't have hard fast rule for it. Sometimes, for example, for me, it could be okay, it could be simple enough, but for another modeler, perhaps it's not adequate, it's not representative enough. So if I may advise, in order for you to come up with the structure of the model, you have to look back at your research objectives and your research questions. If with your model that you have designed able to answer your research objective, for example, you wanted to know what is the ICER of hip fracture treatment with internal fixation versus prosthesis, for example, right? So if that model can answer your question, it should be adequate. But if it's uncertain whether, oh, it's hard to measure because you have the third intervention, for example, right? You have pharmacological treatment, you have injection, you have fixation, you have prosthesis, physiotherapy. So if many intervention, then if it's not enough, so you have to rebuild your model to make sure it can help to answer your research questions. And the other advice that I can say is that because most of the time you are dealing with disease, with treatment, right? And like for me myself, I'm a public health doctor, but not a clinician. So last time when I did my clinical was years ago. So perhaps I don't know well about the clinical setting. So if I may advise, we have our clinician in the team so that, or other experts in the team so that they can give input whether this model represent the condition adequately or not. Yeah. Thank you.
Is there any further question, Ibu Dia? Okay, thank you, Dr. Amirah. And the next question is from Muhammad Arbi and Rizky Salasita. So the first one from Muhammad Arbi about the discounted term and uncertainty. Can you please provide more details? I don't know. So at the moment we have 40 minutes until the next session. So actually I'm flexible whether you are going to answer this during the training or now.
Alright, okay. Perhaps I'll try to answer these two questions first. Okay, so for discounting formula, I can't remember it offhand because I usually have it in my Excel. So, but the point is that you have to compare you will have some discount formula. It's a generic one. You can just actually Google or use your textbooks, right? You have the discount formula, and then you can just to plug in the cost. It affect it. You have to like get your data about your current situation in your country, the cost in your country, something like that. So you can plug in the formula, and you will get the discounted cost. So if I can share, discounted values based on WHO range from 3 to 5%. That means you have to put the weightage, right? From year 1 cost, year 2 cost, year 3 cost, so on and so forth. So the values that you can use is 3 to 5%. But it is not fixed. If you have data of your own country, if you wanted to put higher discount rate, okay, but that is what recommended by WHO lah. It's 3 to 5% discount rate values. Yeah. And then for uncertainty, like we said, the uncertainty, perhaps this one, we will see it better with the hands-on later on. So whereby we can see the range of minimum and the maximum and how does it affect our outcome. So I'll show it in the hands-on later on. And then, okay, the final question for now is, I would like to ask if doing the annuitization is mandatory. For instance, if we are conducting analysis of cancer drug, what kind of capital cost can be annualized? Okay, this is a very good question. So annualization, as we mentioned earlier, we have to consider it for capital cost or for assets that you have to incur the cost in the first year, but it's depreciate over time. So what is an example? Building, transport, big assets. For example, your sophisticated machine, like your MRI, your in my setting, we have fibroscan machine. So those are very expensive, but you have to bear the cost in the first year, but it will depreciate over time, right? So usually, if I can advise, you have to put the annuitization formula for assets that you can use it for a long time and it's depreciate over time. So like consumable, like syringes, right? It's like disposable, right? You use once, you throw away. Or perhaps your cotton ball, even though you buy in the bulk, but it's used once and throw away, right? So those are the things that you don't have to annuitize. But assets, you have to annuitize. And if you're referring to the textbook, I would suggest the Drummond textbooks for health economics. It has the annotation table, so you can choose like you want to have asset for 3 years. So there is a table for 3 years with several discount rate. What is the factors? Then you plug in your formula to get the annualized cost to reflect the cost in year 1, year 2, year 3. For example, our car, right? We have to pay, like in Malaysia, we have to pay like 900,000 car, but you have to give the cost for every year. You have to annuitize for at least 5 years, for example. Then the car has no more value, no more monetary values. So you have to choose annuitization factor, use in the formula, and then you can get the annualized cost. Okay, in your condition, if you wanted to study on cancer drug, what kind of capital cost can be annualized? Okay, so this is also a good question. It depends on the cancer drug. For example, what cancer drug? So you have cancer drug A and cancer drug B, right? If this cancer drug will be delivered in the same hospital, in the same setting, right? The only difference is just the drug, the personnel involved, the investigation needed with the drugs, so on and so forth. So if the capital is the same, actually you don't have to include it, because if you include it, it will be the same, right? With your ISA formulator on, it will be slashed out anyway. So but it doesn't wrong. If you want to include, it's okay, but just to have an idea that later on it will be slashed out if both will incur the same cost, right? Because of the formula, right? Cost of new minus cost of old, right? But if, for example, for drug A, you have for cancer drug A, you have to give it in primary healthcare setting. For cancer drug B, you can only deliver it in the hospital setting with clinic, with consultant, with ultrasound guided, for example, for whatever reason. So because of the different setting, then you have to include capital cost in that analysis. Okay. So okay, final question. Does annuitization somewhat similar to discounting, but we do it for a building or device machine? Not really. First, it has two different formula to annuitize as well as to discount. So why it has two different formula? Because it carries different meaning, right? So for discounting, because of your preference, you prefer to have it now, the outcome now, pay later, right? So if you have to pay now, you feel the weightage is higher, right? For example, it's 7 rupiah. Every year you have to incur 7 rupiah. But 7 rupiah now, it's quite a lot for me compared to if I have to pay 7 rupiah later, right? Because of the time preference. So that is how discount rate is defined. For annuitized, you really have to incur the cost at the very first year. You can't incur the cost in subsequent years, only in the first year. If you want to have it, you have it now. You have to pay now. You can't like distribute the cost later. So, but because you have to pay now, and the use of that asset can be used for several years, right? So that's why you have depreciation over years. You can use it over years, but it's depreciate. So that's why you have to annuitize the cost. You have to put the cost for this year, even though like 700,000, but in first year the cost is 10,000, for example. Subsequent year is 1050, 200. So those are the how you annuitize it. Okay. Is the discounted terms related to inflation? All right. So inflation is another terms in economics. So inflation is like nasi lemak, right? If you know nasi lemak in Malaysia, last time when I was small, nasi lemak cost me only 50 cents. Right? But because of inflation, now nasi lemak cost me 5 ringgit, for example. So inflation actually, it's affected by many external factors like our country's income, our GDPs, right? World Bank. So that's how inflation. That means the cost now, the 5 ringgit last time, 5 ringgit, the value of 5 ringgit last time is not the same as 5 ringgit now. 50 cent last time I can get nasi lemak, 50 cent now I can only get air masak, for example, or one kuih, for example. So that's the value. Inflation talks about value of the amount of the same amount throughout the years. Okay, discount is a time preference. Amortization is when the first year cost, but you put it in years. What are the costs in years? Okay, all right. I hope that's help. Okay, so perhaps I can share my screen again and we continue our hands-on session. Okay. All right. Okay, so. Okay. Can you see my slide? Okay. All right. Okay, so we are going to develop our CEA model in TreeAge. First and foremost, this is the link to download it. I believe the organizer has also shared it with everyone here. So this is how TreeAge looks like. Okay, I understand that some of perhaps if you listen to the other presentation, they call it TreeAge. But for me, I am more comfortable to call it TreeAge. Just because triage means something else in my hospital. That means in ED setting, right? When we triaging our patient. So that's what we call triage. And I am more comfortable to call it TreeAge. So in any way, this is the software. So it has many things in it, right? So here, the white place here is the place where you can draw your decision tree later on. Okay. So here, if you can see, this is the files here, right? TreeAge, I believe that again, like Prof. Syed said, we are not the distributor of this software. We are just the user. But what I like about TreeAge so much is that it comes in a package in which that it has many files here for you to do to try. If you don't have any idea on how to do it, right? So you can just click any of this file and see how does other people develop the model. So you can learn a lot from the examples given by the software. It's in the software itself. All right, and then this is the place below here is the place where you can put all your variables of all your data. So for example, your cost data, your outcome data, your probability data. So this is the place. All right. Okay. Later on, we will also talk about the notes here. This is very important, the notes. Okay. All right. So again, this is the common structure of decision tree. You must have one decision node, or otherwise known as choice node, one chance or event node, and you have to complete your tree with terminal node. Yeah, if one pathway here, for example, don't have the terminal node, so the software cannot be run effectively. Okay, you must end every pathway with decision node. Yeah. Okay, so one of the common question that I received is that can we have more branches here? That means can we have like from treatment here we have for example radiation, surgery and radiation. Perhaps we have another here is physiotherapy, for example. So another branch here, pharmacological therapy. Can we have it? So the answer is yes, you can have more than two treatment. Just now in the notes, right, we say that at least two intervention, but in the software you can run more than two intervention at a time. But please remember that even though you have several interventions in your decision tree, the way this software works is that it can only help you to come up with answer of two intervention. Okay, that means if you have, can you imagine you have four arms here, right? So when you have the ICER, you can only have ICER first, ICER between radiation and surgery and radiation. Number two is ICER between radiation and pharmacological. Number three is ICER between radiation and physiotherapy. So you can't have like three treatments with one ICER. That doesn't work that way. So the ICER can only be you can only derive the ICER from two treatments. Okay. So you can imagine if you have more treatment options, so you have several, you have more ISIS. So you really have to read the output of the software, what ISIS that is actually reported here. Okay. So again, this is the chance node and this is the terminal nodes. Okay, so this is a repetition. You must have one decision node, only one. You cannot have two decision node. Even though with one decision node, you can have more branches actually. Just that you must have one decision node only. So you cannot have several decision node at a time. So this is chance nodes or event nodes and the outcome nodes or terminal nodes. Okay. Alright. Okay, so this is the elements of a tree. You must have one decision node at the root, one only, and the branches of the initial decision node represent all the strategies that are to be compared. So the initial branches here, they reflect the decision that you would like to compare. And then a series of chance node, right? You can have chance node. So pathway after the chance node, you can have several. And then the outcome of the pathway, that means the cause and also the outcome. Okay, so let's get started to build it. So we are going to build a decision tree structure first, and then we are going to populate our model with the values, and finally we analyze it. We will come out with the ISA and uncertainty analysis. So when you open up your TreeAge, this is the first thing that you are going to see. Yeah, it has this create new model, so you can choose from this model, right? So you other than decision tree, actually perhaps later on, if we have an opportunity to conduct this workshop, we can learn about Markov model, right? The one that I mentioned earlier, the more complex one. In fact, we can also run the survival analysis model or the state transition diagram. So these are all the possible things that TreeAge can offer. All right. So once, if you wanted to do decision tree, you have to choose this one. If you choose with assistant, so that means you will be guided, but some values are there. But if you wanted to put your own value, you must choose this one, the below one. So you choose the decision tree, and then you choose cost effectiveness, right? We are going to conduct cost effectiveness. Okay, and then this is the willingness to pay or the threshold. Remember, we must have the threshold, right? For us to determine whether it is cost effective or not. So that threshold, you have to put it here, the values of that threshold. And then, okay, this is the place where you will tell the software how you want your outcome and your cost to look like. For example, you want your cost, right? For cost, you want 2 decimal place. So you tell the software 2 decimal place. And then you wanted it to be in currency. So like mine, because I bought it for Malaysia settings, so this MYR will be appeared here because I choose currency. And then for effectiveness, you can also tell the software how many decimal places that you want. 2 or 3, right? So I am comfortable with 2, so you can choose 2. And then you can put a suffix or prefix, right? Like this one, they use life years, yeah, life expectancy as the outcome. And then you can press the finish back. Okay, so you will see this once you have set up all the things prior to your structure. You will have this. And then what you can do, you can tap on the blue box, double tap, and then this branch will appear. Double click, and then this branch will appear. Okay, if you okay, or otherwise you can use nodes and add branch. Okay, and then you double click again this green, these two will come out. Okay, so again, this is your condition that you are going to study. This is the options that you are looking for. This is the pathway. Once you have this option, what will happen, right? So these are the pathway. Okay. So for example, strategy 1, this is the things that can happen. Okay, so you need to put the probability. Remember, you must tell the software the probability of developing this outcome for strategy 1 is what. So you have to tell the software where do you want to tell, or where do you want to input to put the data? Here in the variable properties. Okay. Then you have to create the probability. So when you put the plus button, when you press the plus button, this one will pop out. So you can see, for example, I want to input data on probability. So you can put your probability data. Okay, like this. This is the best part about TreeAge. You can use the hashtag button, in which that if you have a probability of 0.7 here, hashtag means the remaining. So the software understand that probability has to be 1. So if it's 0.7 here, straight away this will be 0.3 without you have to put the probability in this variable properties. Okay, it's okay if it's too fast. Later we will go step by step in the real software. Okay, finally, as we've mentioned before, you have to end your tree with terminal nodes, right? If it's in this condition, like in the chance node here, nothing won't happen. You cannot generate ISA. So that's why you have to end it with terminal nodes. Okay. So once you choose the terminal nodes, this one will pop out. So it tells you what cost that you want to calculate, what effectiveness that you want to use for your ISA. So you have to put the data here. So at the end of the day, this is the complete structure of the TreeAge for your model. Okay, all right. So later when you analyze it, it has analyzed here, right? When you analyze it and say you want an ISA, so it will tell you the ISA. So later Dr. Hafiz will teach you how to interpret these ISA results. Okay. And then you wanted next to do sensitivity analysis, right? Remember? So what you have to do, you have to press the analysis button, sensitivity analysis, and choose the tornado diagram. So in this tornado diagram, you have to put the range just now, right? So like in our condition, we put, for example, the range is from 0.5 to 0.7, for example. Okay. And then this one will come out. So this is the tornado diagram, which again will be shared by Dr. Hafiz, and Dr. Hafiz will tell you how to interpret this. Okay. All right. So now let's do it. Let me have my other laptop. Okay. So now we are going to conduct a decision tree analysis of two treatment scenarios. That means the standard treatment, which we call as radiation, and the new treatment, which is surgery and radiation. That means the combined treatment to treat cancer cases. Okay, so which one would you choose? You're not sure, right? You were given a task to conduct this economic evaluation. So which one to choose? So we are going to put all this data in your model later on. Yeah, this is the data that you are going to use to populate your model. Okay, so let's begin. All right. Okay, again, when you press, can you see my? Okay, can you see my TreeAge software now? Right. Okay, all right. So you can see, right? This is how the real TreeAge looks like. Yes. So once you press the just now, right, the decision tree, or perhaps this one because I already opened it. So when I press the plus button, so this one will come out. So the software asks us, do you want to run the model setup visit to configure your model's calculation methods and outcome? So what do we have to answer? We have to say yes. So once you answer yes, so it will bring us here. So we have to choose cost effectiveness, right? Then next. All right, again, willingness to pay. You have to decide based on your country's willingness to pay, or if your country doesn't have it, like us, we don't have our own willingness to pay, so we use 123 GDP as recommended by WHO. Okay. Okay. So you can choose this or not. This is just to give you extra features in which that you will have one button later on. If you press that button, the result can come out straight away. So you can either choose it or not. It's up to you. And then next, just next. All right. Next. Okay, here is the things for cost, right? Again, for cost, how many decimal places you want? You want 3, for example, so this one will come out. If you want 2, this is how it looks like. Okay, and then you can, for example, you want separators, because sometimes my brain is hard for me to look at long numbers, right? So I need separators, so I can put separators. So what are the unit? Currency, because it's cost. So like I said, because mine was set up for Malaysia, so it's RM here. Perhaps others, but it's actually you can change it late once you purchase it. You can change the setting if you want it to be USD, so on and so forth. Okay. And then for effectiveness again, you want 3, 4, 5. Okay, it's up to you. So for me, I would like to have 2, and then in this condition, we wanted to have the life years, right, as the outcome or life expectancy. So I can put it life years. So it will be like this. If it's prefix, it will appear in front. This is just a preference. When I attended this workshop back in 2017 in Glasgow, so the speakers said that for him, he likes to have the prefix for currency and suffix for effectiveness. But then again, there is no hard pass rule for it. It's up to you actually. All right. So once you have complete all, just finish. All right. So everyone with me, if you have any question, just raise your hand, okay? Or put it in the chat box. Let me see. Okay. All right. Okay. So again, what should you do? Now you should double tap, right? This blue, right? You see my cursor, right? So what I did, I double tap. Then when you double tap, you can have the branches. Okay. All right. So what is our just now what we want to study? We want to study about cancer treatment, right? So look back at the PowerPoint. Okay, so we wanted to study about cancer treatment. So we can say cancer treatment here. Cancer treatment, right? Okay. So what are the options? The option is we have alright, we have standard. Okay, perhaps if you don't want to have standard, you want to just call it radiation, also okay. It's up to you. Okay. For me, I just follow what we have in the PowerPoint. So for example, standard treatment. Okay. And radiation. Right? So this one is new treatment. So we are comparing standard treatment and new treatment, whereby new treatment will have radiation and surgery. Radiation and surgery. All right. Oh, wrong. Okay. Okay. And what will happen? So we said that with this option, the treatment option, we can have one is tumor eradicated. Let me see, so that we will have the same thing. So tumor eradicates. Okay, so it is eradication. Okay, tumor can eradicate. For example, this one is tumor fail to eradicate, yeah, or you can just put it whatever you want, fail or eradication, fail to eradicate, for example, right? So similarly for this treatment option, you double tap this, so this one will come out. So again, this is tumor eradicated. Okay, so this one failed to eradicate. All right. So remember that this is a mathematical model. So we must put numbers in this structure, right? So you have to put the probability. What is the probability of tumor successfully eradicated with this treatment option? So perhaps the probability that we have here is 0.6. So okay, there are many ways. If your model is not that complex or not so many branches, you can simply actually write 0.6 here. Yeah, you can do that. But other option is that you put in your variable properties, right? So what you have to do, you press this plus sign. Okay, so variable one is say probability tumor eradicated with radiation. Okay, one thing about here, it's like our SPSS, right? You cannot have spaces. If you have spaces, they cannot have like this. If you put here, see, a valid variable name, only letters, digit, underscores. So you cannot have space. So you must put underscore. Okay. So what is the value? 0.6. So put 0.6 here. Okay. Apply and close. So you have one variable. So this one, it's show in 3, right? If you don't want, if it's too messy, for example, you don't want, you just untick it. So it's not appear. So if you want to see, you tick it. Okay. So let's put all the variables. So variable 2 is probability tumor eradicated. What is it? Radical and radiation and surgery. I call it red line, red and sorry, see, cannot have space, surgery. So the probability is 0.8. So apply and close. All right. So that's about probability. Okay. And then we have to include the effectiveness, right? Okay, effectiveness in terms of life expectancy just now, right? Okay. So you can say effectiveness, eradicated. So it's 10. Okay, what does this 10 means? That means, okay, because you have limitation here, cannot have space, so you can put your description here. For example, you can say life years expectancy if tumor is eradicated. All right. Okay. So you can put here, apply and close. Okay. Similarly, you can have just follow the table that we have provided in the slide. The effectively not eradicated. So that means it's life years expectancy. Life expectancy if tumor is not eradicated. So what is it? It's 3 years. 3 years. So apply and close. Next, about the cost, right? Remember, the takes 2 to tango, so you must have effectiveness as well as cost. So cost of radiation. Okay, it's up to you. If you want to have description, you can add cost of radiation. Right, so the cost of radiation is 30,000. 30,000. So apply and close. So again, you can have cost of surgery. Cost of surgery, right? So this one, cost of surgery. So cost of surgery is 50,000 higher. Okay. And then, okay, can we stop here? Actually, we can if you want to, but it's up to you. For example, if you think that no, not only that, because life expectancy is 10 years, 3 years after we treated the patient, so there must be a follow-up based on the clinical input, right? So you must add cost of follow-up. Okay, that's why for you to conceptualize your model, you need input from experts, from studies, literatures, right? So you say here, cost to follow-up. So say 2,000. All right, so apply close. So Now we can populate our model. Okay. One thing about this, if you can see this triangle, small triangle, right? You can move it here. See? So if you want to have like one line all together. So if you have this, the minus, this one is to make your model smaller. If you plus, to make your model bigger. If you want to do anything, you have to choose the arrow one. Yeah. If not, you cannot move. Okay. All right. So now, okay, what is the tumor eradicated? Right. So you can again you can type, or what you can do is you can go to this one, go to function, and then you can choose from here, right? So this one is tumor eradicated radiation. So you choose here. So here the value will come out. So 0.6, right? So remember, one thing about TreeAge, you can just put hashtag. So they will calculate for us. If it's 0.6, so what is the remaining here? So it's 1 minus 0.6. Okay. Similarly here, you want to put the probability, you can choose. There are many ways, right? Like I said, you can type, you can simply type, or you can choose function, and then you can choose this one, right? So when you choose, this one will come out, you put it here, all right? Then again, you put hashtag, okay? So this is the thing that you have to do. So like I said, you must remember, you have to answer it with terminal notes, right? So you press the circle one, change type, put terminal. When you put the terminal, so this one will pop out. So the software will ask us, for example, dear user, what course would you like to consider? So you have to think. So now we are for standard treatment, tumor eradicated, right? So what is the cost? So we go to the function here. So we know the cost of radiation, right? Cost of radiation. And then we said from our clinical setting, after radiation, there will be follow-up. Follow-up based on what? Based on life expectancy. So you have to plus, plus open cost of follow-up times life expectancy. All right. See, when you put in here, so straight away they will calculate for you, right? This is the cost. Why you have this? Can't you have cost of radiation only? Yes, you can, but it is based on your clinical input. That once the patient has, even the tumor is eradicated, they have to be follow up based on your life expectancy, right? So that's why you have to put this cost. So you put okay, and then effectiveness. We just say that the effectiveness here is effectiveness if eradicated life expectancy, right? So okay. So you have to do all of these for all of the pathway here. So I've done before. So this is things that you will put in. Okay, all this. So what you have to do next? Okay, you press the blue here, the decision notes here. What you have to do, you just have to analyze, right? So you put analyze, go to your cost effectiveness. Okay, cost. So when you go to the cost effectiveness, the graph, one graph will come out. Yeah, it takes time. Okay, so this graph will come out. Okay, so this graph will be discussed by Dr. Hafiz. How are you going to interpret this graph? Okay, somehow graph only is not adequate, right? So we wanted to read the report. So we press the text report. So this one will come out. So again, this one also will be teach by Dr. Hafiz on how to interpret the results. Okay, okay, that's how you generate ISA from your model. Okay, now the last step is tornado diagram, right? Our uncertainty. So just one step. So what you have to do again, you must press the blue here. If you not, this software cannot identify which one are you talking about. So you have to make it blue here. So you press sensitivity analysis and then tornado diagram. Okay. All right, here. So because this is by default, the value has been entered before. Okay. So you can see that this is the low value and high value, right? Okay. If I cancel it, for example, and look back here, So for example, this is the value, but that one is the low and high. So where to put the low and high value? You go here. Okay, this is the pencil when you want to edit anything. You have this one, sensitivity analysis, right? So you can put the low value and high value. Okay, so you can put for relevant parameters if you wanted to conduct any sensitivity analysis. Okay, so next is tornado diagram. So you have all the values. These are the values. I assume that in my case, all of the parameters have the low and high values. So I put it here. Then I said okay. So when I said okay, it will take some time. So ISA, I want ISA, right? So open report. So finally, oh sorry. So finally, this one will come out about my tornado diagram. Okay. So again, later, okay, you can close it to make your graph better. So this is on the deterministic uncertainty analysis or tornado diagram. So to answer the question just now, how to conduct uncertainty, right? So actually, the step that is very important is to put the low value and high value. So with that, this is what will happen. So this reflect the low and high, and there are ways to interpret this, which will be discussed by Dr. Hafiz. Okay, so perhaps I will stop here first. We will not proceed with the probabilistic analysis because it's require more data. So I will stop sharing first. So is there any question before I start and pass it to the Hafiz? I think I took 2 extra minutes. Sorry.
Any questions or perhaps any steps that maybe need to be explained? I mean, revisit. I mean, the steps of the TreeAge, please.
What question from?
Yeah. Please. Miss Rizky Salasita.
Thank you very much, Dr. Amirah. So actually, this might not be, this hasn't been explained yet regarding the sensitivity analysis. But other than tornado analysis and probabilistic sensitivity analysis, I think you earlier mentioned about the one-way sensitivity analysis. So for the one-way sensitivity analysis, like in the TreeAge software, are we also requiring more data, just like the doing the PSA sensitivity analysis, or we can, like directly on the software modify the low value and high value, so it's not required to have more data?
All right. Okay. So thank you for the question. So deterministic analysis can be in many forms. It can be in one way, two way, three way, right? If you can see in the TreeAge just now, right? So it's actually one way, two way, three way is part of deterministic analysis actually, whereby you determine the low and the high values for the uncertainties. That's how deterministic analysis is defined. So for one way, that means you actually there are many ways. If you wanted to you choose the tornado diagram like I did, can, but then you just say that one parameters only that I want to check for the uncertainty. So you can delete the other parameters. You go to that particular parameters and put the low and high values. So basically, one way, two way, three way, or deterministic analysis, it talks about low and high value. Yeah, does not have to. You don't have to get the distribution data. All right. Or alternatively, like you said, you can choose the one-way sensitivity analysis. So it will pop out only one variables that you can put in to run the uncertainty analysis. If you choose the two-way, only two variables you can put in for uncertainty. So to answer your question, it does not have to get the distribution data, not that intensive as probabilistic sensitivity analysis, and it is part of deterministic analysis. So you can choose to choose the one way or to another diagram. It will lead you to the same result.
Yep. Wonderful, Dr. Amirah. Any other questions? So we still have 5 minutes before we start Dr. Muhammad Hafiz's session. Well, maybe perhaps any participant want to proceed to the Markov model or so.
Yes, yeah, it's good actually. If once you have the feeling of doing Markov, I think decision tree is way simpler. You can feel that decision tree is way simpler.
Okay, thank you, Dr. Amirah.
Thank you.
To the participants, or perhaps Ibu Dia has any questions. Oh yeah, Ibu Dia, please, Ibu Dia, thank you. Ibu Dia, you're still muted? Yeah.
Yeah. Thank you, Dr. Amirah. So, do you have any experience when you are a bit desperate because of we don't have enough data? So, what would you do to cope with this situation?
Right. Okay. So thank you, Ibu, for the question. Based on my experience, I also have actually not as vast experience as Prof. So based on my experience, when we have some problem when we can't find any data, right? Two ways that my professor said that we can do. One is to ask the experts. So based on the expert input. So for example, we don't have the probability of people in cure rate pathway when we give this treatment. So we can ask the expert based on your experience from hospital, your clinical experience, what would be the best probability to put for this pathway. That is number one. Number two is we borrow data from our neighboring countries, from published literatures. But then when we write a paper in the limitation, we have to say that this data might not reflect our setting because we don't have the data. So we borrowed data from other countries. Yeah, that could be the possible things lah. Otherwise, if time is not an issue, we can conduct the observation study first to look at the probability. Like you have a trial study, for example, give patient treatment A treatment, you wait until the patient develop the outcome, then you can see the probability there. So if time is not an issue, perhaps you can do that too. Yeah.
Thank you, Dr. Amirah. There's a question from Miss Dwi Novrianda. Do you mind to provide your daughter email, your email, Dr. Amirah, to the participants?
Sure, perhaps I can try with here.
Oh, that's very nice of you.
Okay, no problem. Okay.
Thank you, Dr. Amirah. Oh, we still have 2 more minutes for burning questions. Or if audience allow, I will raise a question myself. Dr. Amirah, do you mind? Well, it's more like a silly question. I was wondering, so the participants and including me, we have the trial version at the moment. So in your experience, when you have something like you need to publish a study or doing so, is it possible with the trial version, or we should definitely upgrade to the pro version? Thank you.
Thank you, Ibu, for the question. So, actually, trial version is fine. You can use that. Of course, it has several limitations in which, like, perhaps there are other analysis that you can conduct, right? Like susceptibility curve. If you are familiar with it, perhaps you might not have it with the trial version. But otherwise, to come up with the ICES, even the uncertainty, totally fine with the trial version. But things that you have to remember with the trial version, it only lasts for 30 days. 30 days. So you have to ensure that your data is available so that you can simply plug in the model and run it. And the other thing is that the distributor is, they are clever, right? They save your IP address and your device number. So once you have downloaded the trial version, later on, if you want to try to re-download another trial version, it is not possible because they store your IP address once you download it. So you have to download it in other device. So yeah, that's the challenge part of the trial version.
Yeah.
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 So otherwise, what if you still want to use trial version, I would suggest to store all your data in an Excel or other form that you can save it. Then only you transfer it to your TreeAge so that you have the initial data. If you only save it in your TreeAge, you might lose it once the software expired.
Thank you, Dr. Amirah. Pardon my silly question. So, let's carry on to Dr. Hafiz's session about interpreting the cost effectiveness analysis using the TreeAge software. So, what's next after this? Please, Dr. Hafiz, the time is yours.
Right. Okay, thank you very much for the organizer. Okay, let me share my screen first. All right. Okay. So now it's my turn. Thank you very much for inviting me to this workshop. Okay. My name is Hafiz. I'm from University Science Islam Malaysia, USIM. I'm a public health lecturer and also a public health physician in Malaysia. So for previous two sessions, you've been explain on the importance of modeling, importance of economic evaluations. Okay, and you have very nice sessions, practical sessions with Dr. Amirah as well on conducting the cost effectiveness analysis using a decision tree model. Actually, it looks very simple, but in real situation, in real study, it is more complex and complicated, I would say, especially when you want to design the structure of the model. And once you design the structure, you also need to put the inputs. The inputs is the challenging part, whereby you need to do lots of literature search and also interview with experts to get the data. Okay, so the topic of my presentation today is on the interpreting results of CA model. All right, these are the outlines of my presentation. I'll start with explanations on what is ICER, and then we also have some brief overview on CE plane before we focus more on CE results based on TreeAge software in terms of the graph as well as the report. And a bit on the sensitivity analysis. I'll focus more on the deterministic part and also interpreting the tornado diagram. Okay, what is ICER? Okay, ICER is actually I is for incremental, C is cost, E is effectiveness, and R is the ratio. So basically, ICER is the ratio of different in cost, okay, and also different in effectiveness. If you can see from the formula given here, okay, ICER is actually C1. C1 is actually the cost in intervention group minus C0. C0 is the cost in control group or standard treatment. Okay, E1 is the effectiveness in intervention group, and E0 is effectiveness level in standard or control group. So C1 minus C0 divided by E1 minus E0, then you get the ratio of different in cost and also different in effectiveness. Okay. So next we move on to on the CE plane, cost effectiveness plane. Okay, as Prof. Syed has mentioned earlier, there are 4 quadrants in CE plane: quadrant 1, quadrant 2, quadrant 3, and quadrant 4. Okay, the x-axis of this plane is actually the effectiveness level. As it moves to the right, okay, the new treatment become more effective. As it moves to the left, okay, the new treatment become less effective. As for the y-axis is on the cost. Okay, as it move upward, the new treatment become more costly. As it move downward, the new treatment become less costly. Okay, as you can see here, for example, if let's say you conducted a CAA and then you got your ISA value, and then let's say your ISA value falls on the quadrant 4. So if let's say your ISA value falls in quadrant 4, so your new treatment is actually less effective. At the same time, your new treatment is more costly. So in this scenario, the existing treatment is better. So you call it as a dominates. So existing treatment dominates. Okay, it's a clear cut that the new treatment costs you more but less effective. So you don't want to use that. Okay. In contrast, if let's say your ISA fall into quadrant 2. Okay, in quadrant 2, the new treatment is more effective and at the same time less costly. So this is actually a very good scenario, because the introduction of new treatment will have a better outcome and at the same time less cost. Okay, this is a very clear-cut decision that need to be made. But if let's say your ISA fall into either quadrant 1 or quadrant 3, it's a little bit tricky. Okay, I am not so sure. If let's say, for example, it falls into quadrant 3, the new treatment is less costly. Okay, you can save money, but it also less effective. Okay, or in quadrant 1, the new treatment is more effective, but more costly. This is a common scenario or situation that we face every day when we conduct a cost effectiveness analysis, because new treatment is always more expensive, but they promote that it is more effective. Then how to decide? That's why we have the dotted line. The dotted line is actually the maximum acceptable ISA, or as explained by Dr. Amirah just now, it is a WTP, willingness to pay threshold level. Okay, so if let's say your ISA fall below the WTP threshold level or below the dotted line, then your intervention is cost effective. But if let's say it fall above the dotted line here, then it is less cost effective, right? Okay, I hope you're very clear with ISA and CA plane, because the fundamental knowledge of this is very important before we interpret our TreeAge output. Okay, so this is the CE result from TreeAge. Okay, once you run your CA from TreeAge, you will get your very nice graph like this. So in this graph, okay, you have again y-axis and also x-axis. Your y-axis is actually the cost. Okay, this is the cost, and your x-axis is the effectiveness. Okay, as mentioned earlier, in order to conduct a cost effectiveness analysis, you need to have cost and also effectiveness level. So the red square here is the standard treatment. Okay, for example, the standard treatment is radiation. Okay, and the blue triangle here is the new treatment, which is surgery and radiation. Okay, so the difference between the standard treatment and new treatment, the difference in the effect. This is the difference in effectiveness. Okay, this is what we call incremental effectiveness from this standard treatment to the new treatment. Okay. Next, we also have the difference in cost. So, for example, the cost for standard treatment is 44,000. But when you introduce new treatment, it will cost you about 96,000. Okay, the difference between these two treatment is what we call as incremental cost. So remember, ICER is actually a ratio between incremental cost and so incremental effectiveness. It is a ratio. So this is your ICER. The slope is actually, you need to differentiate this graph with your CE plane, okay? Okay, this is basically more on the cost and also effectiveness level. Okay, so the slope of the value here, the value of slope rate is your ICER. So the incremental cost divided by incremental effectiveness will give you a slope value, which is your ICER. Okay, this is your graph. Okay, apart from graph, you also have your report. Okay, remember when I mentioned about dominated and undominated in quadrant 2 and quadrant 4, it is dominated either standard treatment or the new treatment. So in your report, just concentrate on the topmost value. Okay, in this part, we have the strategy, which is the standard treatment and also the new treatment. Okay, and then we have cost, and then the incremental cost value, effectiveness, the incremental effectiveness value, and the ICER. Okay, so for example, the standard treatment, the cost for standard treatment is 44,000, whereby the cost for new treatment is 97,000. So the incremental cost is 52,800. And this is the effectiveness, whereby the standard treatment, the effectiveness is 7.2. Here, new treatment is 8.6. So the incremental effectiveness is about 1.4. So our ICER is 37. Okay, so we concentrate more on our ICER, 37.714. Okay, so how do we know that either our new treatment is cost effective or not? Okay, that's why you need to have your threshold value. Okay, WTP threshold value. Later I will show you the graph. When we put the WTP threshold value, if let's say fall below than your WTP, it is cost effective. It is more than your WTP, it is not cost effective. For example, the WTP for this one is about 50,000. So ICER below 50,000, meaning that it is cost effective, right? Next, okay, we move to the sensitivity analysis. Actually, there are lots of uncertainty in model-based study. Okay, it's either based on model inputs. Model inputs is basically parameter uncertainty. It's either deterministic or probabilistic. We also have uncertainty in terms of model structure. This is what we call as structural uncertainty, or methods in modeling. This is methodological uncertainty, or characteristic of the population, the heterogeneity. Okay, these are all other types of uncertainty. But for today, since we are talking about the model inputs, we'll focus more on the parameter uncertainty. In this case, I'll explain more on the deterministic. Okay. Okay, one-way sensitivity analysis. Okay, is actually ask what if. For example, what if for one particular model parameter at a time. Okay, sensitivity analysis was conducted basically to identify key model inputs that contribute to the parameter uncertainty. Which parameter actually contribute to the uncertainty in our value? Okay, and model parameters are actually varied from maximum to minimum values on at a time, and the impact on the ICER is recorded. So basically, it describes the extent that each of the model inputs contributed to parameter uncertainty. Okay, so model parameter that may significantly affect the final result can be identified through sensitivity analysis, and then you can consider what if we increase, what if we reduce this value. Okay, and these results are usually presented as bar chart or tornado diagram. Formally, tornado diagram lah. In TreeAge, they will produce a very nice tornado diagram. Okay, all right. So this is your tornado diagram. Okay, in this, as mentioned by the term just now, when you click on the tornado diagram, they will by default they will include all values in your model, but you can choose which model that you want to include in your development of structure of tornado diagram. Okay, in this case we use all, because actually other type of model we have lots of parameters. So this model we have only about 2, 4, 6. First is probability tumor, and then indicated by radiation, then life expectancy if tumor indicated, cost of surgery, cost of follow-up, cost of radiation, and probability tumor is indicated by radiation and surgery. Okay, in your tornado diagram, you have your ISO value. Okay, in this study, our ISO value is this one. Okay, I think it's about 37, and the WTP value is 50,000. So using this one ISO value, it is cost effectiveness. Okay, so first is probability tumor. So the topmost represent the parameter that have large influence towards your ISO value. For example, if you manipulate or you try to increase or decrease the probability, your ISO will be heavily affected. Okay, next, so have life expectancy. Okay, all right. So for probability tumor, the blue color is actually the beginning, and the red one is towards the end. So it's moved from the blue side to the red side. Okay, so from 0.5, probability tumor is indicated by radiation from 0.5 to 0.7. So as the probability of tumor eradicated by radiation increase, okay, increase from this to this side, your ISO will also increase. Okay, and then if let's say up to 0.651, okay, this is the maximum level lah. If let's say the probability tumor eradicated by radiation more than 0.651, then your new intervention is radiation and surgery. And this one is the standard treatment. If let's say the probability of tumor by standard treatment is more than 0.651, meaning that your ISO will not be, your new intervention will not be cost effective. Okay, your probability of tumor need to be less than 0.651. This is the standard treatment. Okay, right. Next is other parameter is about life expectancy if tumor eradicated. So it start from here 8 until 12. Okay, so the cutoff point here is 8.24. So we expect that as life expectancy increase, then your ISO will decrease. So meaning that if life expectancy increase more than 8.24, then your ISO will be cost effective. If it is from 8 or more than 8.24, if less than 8.24, then your intervention will not be cost effective because it is above the threshold level, 50,000. Okay, this is how you read your tornado diagram. You start with the blue color and then follow to the red one. Okay, based on your WTP value as well as your ISO value. WTP value is the one that you insert before you start your model development. Okay, so basically your ISO is largely influenced or affected by if with this parameter, probability tumor is eradicated by radiation, okay, and also by life expectancy. Right. We also have cost of surgery. As cost of surgery increase, your ISO will increase. But this one, the range is between 40,000 to 60,000. So even at the maximum level, 60,000, it will still be cost effective. Right? But your ISO will increase because your cost increase. And remember, ISO is cost divided by effectiveness. Right? If let's say your cost increase, your ISO will increase. But even at the maximum level of cost, your ISO still did not exceed your WTP level. So it's still considered as cost effectiveness. Similarly, cost of follow-up per year, even at the maximum level, will not affect your ISO, will not give a significant influence to ISO. That's why the graph graph, the bar chart is very, very small. Okay, the thickness is very, very, very small graph. Okay, next is on cost of radiation. Okay, another one is the infinity sign. Okay, this one is a probability tumor irradiated by radiation surgery. We're not so sure about this. Okay, that's why the ISA value is infinity. Okay. Okay, this one, I just want to highlight the WTP value. Okay, you need to make sure that the cutoff point to ensure that either your intervention is cost effective or not cost effective. So this is the value. Again, the WTP value depends on your country, and at the same time, in Malaysia we use 1 to 3 GDP. Okay, there are in some country, in developed country, maybe they have their own willingness to pay different from each country. Okay, this is cost of radiation and also probability of tumor eradicated. Okay, that one is deterministic sensitivity analysis. Okay, now on the probabilistic sensitivity analysis, the difference between deterministic and probabilistic is that probabilistic give you you need to input more data. Okay, for example, in this CE plane here, if in deterministic you have just one dot and you can decide easily. If it, let's say it is below, then the threshold level is cost effectiveness. If it's more than threshold level, is not cost effective. Okay, so in this case, let's say when we conduct a probabilistic sensitivity analysis, we have lots of data and lots of value, and we need to identify, okay, the most concentrated area or part and the most dense part. So in this example, it is actually the most dense parts is below the threshold level. So we can say that it is cost effective. Sometimes if let's say the most dense parts or most concentrated part is above the threshold, it will not be cost effective. And sometimes, okay, sometimes it falls between, because we have lots of data, okay, compared to one value, it falls between the threshold level, okay, it's equally distributed between these two area. So in that case, it's difficult for us to conclude. We might need to have a look at our model, at the parameters, and then try to look for better data, and have a look back at our model constructions and also our input that we put during the model development as well. Okay, right. So I'm not going to detail because probabilistic. The difference between deterministic and probabilistic is that probabilistic you need more data, okay, more value to come up with the more than one ISA. All right. So in short, okay, because the timeline has explained in details before this. In short, in order for you to conduct CA, you need to first calculate your ISA. Okay, how to calculate your ISA is through TreeAge. Okay, I can calculate through TreeAge based on your model, basically from your model. So in order to get a very nice model, you need to have a very good input, because one of my essay will say garbage in, garbage out. So if let's see the quality of data is very poor, and then you do not have enough information, then the output will be some things that will not be useful. So model construction, model development, and parameters and input that you put is very important in order to have a very good cost effectiveness analysis. Next, apart from ISA, you need to know your WTP threshold. Okay, if let's say a country have your own WTP level, then it's good. If not, then commonly we use the GDP level. Okay, then once you have your ISA, you have your WTP threshold, you need to conduct sensitivity analysis, because in model we have lots of uncertainty. So we need to have a range of options, okay, to decide on the final outcome or final output. And then under sensitivity analysis also understanding the tornado diagram to understand what parameters actually influence the ICER and your decision later. All right. Okay. All right. That's all. Thank you very much. Any question?
Thank you, Dr. Thank you, Dr. Hafiz, for the session, for the explanation about how to interpret results of cost effectiveness analysis model using TreeAge. So this is the almost near to the end of the short course for the morning session. We have until 12:20, or actually as long as our panelists willing to provide the answers. So please, for the participants, if you would like to raise question about the interpretation of these cost effectiveness analysis using the TreeAge software, or I think it's okay too, since Dr. Amirah is here, perhaps some of you may have a question for Dr. Amirah's session. I think it will be good, so we can kind of give like a complete wrap up for our workshop today. Any question? So here's we have here from Ms. Rizky Salasita. So yeah, as we can see in the screen, in the chat box, if we conduct the analysis by taking the parameter data from the literatures and the literatures do not provide much info on the distribution, how do we conduct the PSA or get the distribution data? So Dr. Amirah or Dr. Hafiz can answer to that question.
You are unmute. You are unmuted, Amirah.
Can you hear me now?
Yeah, we can hear you.
Yes.
So thank you for the question. So I believe that this participant would like to know if the literature that we referred to don't have much info on the distribution, right? So how are we going to conduct PSA? So it was a good question. In my opinion, for this, actually we have to refer to several literatures. You don't have to limit to one literature, because I do agree some of the, especially the earlier studies, whereby at that time probabilistic was not the in trend at that time, or with deterministic is adequate. Perhaps they only have limited values, but with the current papers, you will find that they have many more values that can help you to run the probabilistic sensitivity analysis. And like Prof mentioned right now, high index journal, if you want to publish our findings of CA, especially for example the ISPOR journal, right? They have economics journal, so they want us to produce this probabilistic analysis for our students. Yeah. Does that answer the question?
Maybe I can just add a bit to Dr. Amirah's view. Yeah, I mean, we are doing the PSA. It is a bit data hungry, so we need to get more information. But anyway, if we are not able to do that, I think we have to go down to deterministic sensitivity analysis. It is still acceptable, but it's a bit less, more difficult to get publications from that. So if we have information, then we'll go for PSA. If we don't, then depending on your luck when you try to publish it, I think sometimes it's acceptable to use a less precise method, or less sort of data required approach. There's another question here. Is there any issues about sample size and also power in conducting CEA? You want to comment on that, Amirah?
I can try from again, it's a good question, and we have perhaps many views on this, especially when we talk with our statistics friend, epidemiologist friend, right? Whereby they usually wanted to have a sample size to represent their population, right? That is the main reason why we calculate the sample size, because we can't do to all, so we have to sample it. So we want to ensure that our samples represent the population. So that's how I believe epidemiology studies will look at it. But for CEA, when we conduct, we usually do not need that information. So we are not representing the population anyway, right? We are comparing the intervention. So my answer would be yes, if you want to combine with epidemiology study. For example, you are looking at epidemiology point of view and economic point of view, how much you have to vaccinate the people, for example, to reduce the certain disease. So for that, perhaps you need to get some sample size for the epidemiological study, then you plug in your economic. No, if you only wanted to compare the intervention, because it's not to represent the population, right? You are comparing the intervention.
Yeah, thanks, Amirah, for addressing that. This is the problem with economic evaluation, because when we present this in the ethics committee, normally the epidemiologists may not be very happy with it because they have a different views. But you must remember, cost analysis almost always all the time, it is not normally distributed anyway. So how big your data is, it doesn't matter actually, because it will still be skewed to a certain extent. So I believe that you need to explain to them, but if you have very few data points, that might be quite difficult for us to understand, to convince them. But we must actually try to get adequate number to convince the board or the ethical approval board. But remember, we have two sets of information: the information on the cost and also the information on the outcome. I think we have to take these two into consideration. It is important, but it should not be actually viewed from the epidemiologist perspective, because this is a different kind of study. CEA is not an epidemiological study, so we cannot use the sample size calculation that are being sort of favored by epidemiologists. So this is the issue, but I think most of the time we should be able to address this.
Yep. Thank you, Professor Syed and Dr. Amirah. I think Budia have one more question.
Yeah, thank you, Prof. Syed, Dr. Amirah, and Dr. Mohamed Hafiz. Thank you for all valuable information. I would like to ask on a smaller scale HTA. For instance, if we are doing hospital-based HTA, so what data would be used for willingness to pay? Thank you.
Hafiz, you want to address that? You mentioned a lot in terms of willingness to pay. Dr. Hafiz, I think you are muted.
Right. Thank you for the question. Actually, there are a few ways in determining the willingness to pay. The simplest way is to conduct a willingness to pay survey, whereby you have either open-ended or also close-ended bidding, and then to get the average value and to finalize your willingness to pay for that particular hospital among your target populations. I would say so far I don't have so much experience in conducting the 1 or 2 study, but what we did was we conduct a survey to a certain number of people that will be affected with the system, and then in our survey we use open method whereby we try to ask the participants the amount that they are willing to pay, or the amount that they're willing to pay basically to get that service, and then the maximum amount and then the minimum amount. That is the closed open system lah. For example, I give you an example on COVID vaccine. We conducted a willingness to pay study for COVID vaccinations. So we start with an open study, open bidding, and ask the study populations on the amount that they're willing to pay for that, and then from the first amount we try to increase our bidding up to the maximum level, and that is open. And so we also use closed-ended style, whereby we are the one that determine the incremental value for that. So I think that is one of the way to get the WTP value.
Yeah, maybe I can add to that. Where in Malaysia, we are still struggling with the issues of willingness to pay and also the threshold. In fact, you don't have to worry about it if you do not have your willingness to pay figure. To me, I have a lot of reservation in people doing willingness to pay, because in our country, in many developing countries, people cannot appreciate how much is the value of money. Especially in Malaysia, people get almost free treatment when they go to the public facilities. So when you say $1, $2, RM2, RM3, RM4, for example, people cannot appreciate that, because is that the real value that they put in the first place? So WHO over the years has come up with a good guideline. It relates to the per capita GDP. So under WHO guideline, which is still valid today, so you can use this in your study. Anything which is below 3 GDPs is considered to be cost effective. So they use 3 GDP, 3 times GDP, per capita GDP, as the threshold, maximum threshold. Anything below 1 GDP is highly cost effective, and between 2 to 3 is cost effective. So I think in that case for Malaysia, if we have our GDP is 35,000, so probably anything below 100,000 plus would be considered to be cost effective. In that way, you run away from having to do a willingness to pay study, which can be very extensive and can take a lot of time if you want to do that in your study.
Thank you, Professor Syed, Dr. Hafiz, and Dr. Amirah for the answer. Any other question for the participants? We still have 2 minutes until 12:20. So, okay. I guess there's no more question from the participants. It's almost 12:20 anyway. And so on behalf of the committee, I would like to share our sincere gratitude to Professor Syed, Dr. Amirah, and Dr. Hafiz for this invaluable knowledge about cost-effective analysis. I believe that it's gonna be very useful for all of us, and especially me. I don't have any background on health economics, but I can say I really enjoy this workshop. It's very clearly explained, although for the newbies like me. So I believe the participants feel the same way too. So thank you. So I should conclude before we leave. Perhaps Budia want to share 1 or 2 words. Budia.
Okay, thank you very much for all valuable things that we gathered from your experience, and also for the nice discussion among us. And I thought discussion is need to be continue, Prof. Syed.
Sure.
Yeah, so maybe we could also conduct collaborations in doing training in more detail or more technical things that we could raise the issues of the updated issues that Prof. Syed has already mentioned during the discussion. And also we could also share our thought maybe more on see that we are also struggling now on the doing HTA for medical device, Prof. Syed.
Yeah.
So not only the medicine, but maybe doing more variety HTA and shared our experience. So thank you so much for all your time and thank you also for nice discussion among us. Thank you, Prof. Syed,
Thank you.
Yeah.
Thank you so much.
Thank you, Budia. And
Dr. Amirah,
yeah.
Dr. Hafiz.
And yeah, one of our participants already expressed her interest to join the Markov model. So perhaps there's something that we need to consider for the next postgraduate forum in Thailand. So thank you again. Thank you very much for our distinguished panelists and all participants. So I'm Likke Prawidya Putri, closing this session. So for tomorrow we have the conference, the big conference. Do you mind to share the screen about the conference, Mbak Lia? So tomorrow we have our conference held from 9 to. You can all join. So for all the pre-conference participants, you're welcome to join the postgraduate forum, the 16th virtual postgraduate forum on health system and policy, which will be held tomorrow, 15 and Saturday, 16 of July. You can click on the you don't need to pay for the registration because you're already in the pre-conference. So just click the just click the link for just registering your name, or please one of the committee, would you mind to share the link to join in the chat box? And this afternoon, we also have two session short course on using the software R to create a table and also to do the efficiency analysis of the hospital and the health service. So, okay, so that's all from us. Again, thank you very much for all. Wassalamualaikum warahmatullahi wabarakatuh. Selamat siang. Good afternoon.
Hi, I'm Rosie. My friend Matt and I are friends with Assistant Professor Witwichadit, who asked us to make this presentation on his behalf, titled Epidemiologists, Essential Workers of the Future. Epidemiologists are health scientists who study the distribution of diseases in a population. Epidemiologists identify health problems, measure their magnitude, identify risk factors, and identify solutions to these problems. So, who should study epidemiology? This discipline is very useful for scientists who are interested in public health. Epidemiology is also useful for public health people who are interested in science. Now my friend Matt will talk to you about the different fields of study within epidemiology. Matt?
Thanks, Rosie. Hi everyone, I'm Matt. So the word epidemiology might make people think of epidemics or infectious diseases, and they would be right. However, epidemiologists also investigate problems in other fields, including maternal and child health, cancer, mental health, alcohol and substance abuse, and even casualties from violence and armed conflicts.
Graduate education in epidemiology emphasizes data analysis and interpretation, as well as field work and project management. These skills are highly transferable to career fields that are in high demand and deemed as essential for the future. In addition to working as epidemiologists for health departments, graduates of master's and Ph.D. programs in epidemiology are qualified to work and have found employment as data scientists, survey researchers, actuarial scientists, as well as technical consultants for international organizations such as the WHO and UNICEF, especially in the area of monitoring and evaluation.
The curriculum of our master's and Ph.D. programs in epidemiology include basic and applied epidemiology, statistics, qualitative research, and other related skills. During the first year, students take their coursework and gain initial research experience from the week-long field exercise in southern Thailand, before returning to their home country in the second year to conduct research for their own thesis. The research topic can be tailored to the students' and the supervisor's interests. Master's students typically take 2 to 3 years to complete their study, while doctoral students typically take 3 to 5 years.
Thank you for watching our video. We hope that you can join us in Thailand and become a part of our community. Please visit our website for more information. See you soon.
Faculty of Medicine, Public Health and Nursing, Universitas Gadjah Mada has grown rapidly over the years and positioned itself to become a leading institution in Indonesia and in the region. It was established on March 5, 1946 as the oldest Faculty of Medicine in Indonesia. It aims to become an innovative and excellent Faculty of Medicine, Public Health and Nursing with international standards and to always serve the nation and humanity with national cultural values based on Pancasila. The mission of the faculty is to improve public health status through education, research, and excellent services based on local wisdom, ethics, professionalism, and evidence-based science integrated in the academic health system. Various study programs in Faculty of Medicine, Public Health and Nursing, Universitas Gadjah Mada has successfully achieved accreditation, such as TreeAge, Asian University Network Quality Assurance, and Philippine Accrediting Association of Schools, Colleges and Universities at the international level, and the Indonesian Board of National Accreditation for Higher Education and Indonesian Accreditation Agency for Higher Education and Health at the national level. Supported by lecturers, including professors, supporting staff, departments, research centers or working groups, Universitas Gadjah Mada Academic Hospital, Central Public Hospital, Dr. Suraji Tirtonegoro, and Dr. Sarjito Teaching Hospital, which is currently accredited by Joint Commission International for Academic Medical Center. The faculty offers undergraduate programs, graduate programs, medical specialist programs, and combined degree programs. Every year, over 500 undergraduate students and 600 graduate students are enrolled. The faculty continually develops and improves a flagship program called Continuing Professional Development through guest lectures, seminars, symposia, and workshops. Moreover, the faculty is equipped with IT facilities and information systems that are integrated with the university system, video conference facilities and webinar, a computer-based test room in a convenient academic atmosphere, and a green campus. Supported with comfortable workspaces, museums, sports facilities, and disabled-friendly buildings. Active partnerships and strong collaborations have become inseparable parts of our faculty, without which progress in education, research, and community service would not have been achieved. Our international partnerships create ample opportunities for student and staff exchange, research collaborations, community services, as well as development of international double degree and sandwich programs at the undergraduate and graduate level.
As the one of the oldest medical school in Indonesia, we always encourage the quality of interprofessional education, strengthen research collaboration, community services based on local wisdom values, and modern technologies with international standard. Welcome to our Faculty of Medicine, Public Health and Nursing, Universitas Gadjah Mada.
Pusat Kebijakan dan Manajemen Kesehatan atau PKMK merupakan salah satu pusat kajian di bawah Fakultas Kedokteran Universitas Gadjah Mada. Kami berdiri pada tanggal 5 Februari 1998. Seiring berjalannya waktu, kegiatan PKMK yang berawal dari bidang manajemen pelayanan kesehatan beberapa tahun terakhir ini semakin banyak berkembang ke arah kebijakan kesehatan. Hal ini berdampak pada perubahan nama institusi yang semula adalah Pusat Manajemen Pelayanan Kesehatan atau PMPK berubah menjadi Pusat Kebijakan Manajemen Kesehatan atau PKMK. Perubahan ini sesuai dengan persetujuan Senat Fakultas Kedokteran Universitas Gadjah Mada tertanggal 15 Maret 2013. Struktur organisasi PKMK terdiri atas 3 bagian, manajemen, divisi, dan unit pendukung. Manajemen adalah sistem yang mendukung jalannya kegiatan dan secara operasional membantu secara administrasi. Saat ini PKMK mempunyai 5 divisi yang sesuai dengan bidang keilmuannya, yaitu Divisi Manajemen Mutu, Divisi Kebijakan dan Manajemen Kesehatan, Divisi Manajemen Rumah Sakit, Divisi Manajemen Bencana, Divisi Sistem Informasi Kesehatan. Untuk mendukung manajemen dan kelima divisi tersebut, PKMK mempunyai unit pendukung, yaitu unit seminar dan publikasi. Untuk mendukung publikasi, PKMK menggunakan teknologi informasi. Salah satunya adalah penyebaran ilmu berbasis website. PKMK menyebarkan perkembangan ilmu dan informasi melalui website sejak tahun 2010. Website induk yang dikembangkan ialah Kebijakan Kesehatan Indonesia. Setelah itu, dikembangkan beberapa website lain untuk memberi banyak kontribusi terhadap masyarakat luas. Harapannya, website-website ini dapat diakses dan dapat dimanfaatkan seluruh pihak yang membutuhkan. PKMK telah bermitra dengan lembaga-lembaga pemerintah dan swasta, serta lembaga-lembaga internasional seperti SIDA, USAID atau DEVAT, WHO, Bank Dunia, European Union, dan USAID.
Pusat Kajian Kebijakan Pembiayaan dan Manajemen Asuransi Kesehatan atau Pusat KPMAK adalah pusat kajian di Fakultas Kedokteran Universitas Gadjah Mada yang fokus pada isu pembiayaan kesehatan dan manajemen asuransi kesehatan di Indonesia. Berpengalaman selama 13 tahun memberikan pelayanan analisis yang tepat beserta saran kebijakan kepada pengambil kebijakan di tingkat lokal dan nasional. Pusat Kajian KPMAK juga berperan memberikan peningkatan kapasitas melalui berbagai pelatihan kepada pemerintah daerah dan nasional. Pusat Kajian KPMAK melakukan pendekatan secara partisipatif untuk meningkatkan pengetahuan, kemampuan, dan tujuan program sehingga menghasilkan kebijakan berbasis fakta. Pusat Kajian KPMAK memiliki tradisi yang kuat terhadap masalah kemiskinan dan pelayanan kesehatan yang berhubungan dengan health financing reform. Pusat Kajian KPMAK banyak memberikan kontribusi penting dalam evidence-based health financing policy reform di tingkat lokal maupun nasional. Kontribusi dilakukan dengan berbagai cara dan melihat kepada kebutuhan pembuat kebijakan. Penelitian yang dilakukan oleh Pusat KPMAK senantiasa memperhatikan kebutuhan kebijakan pemerintah. Pusat Kajian KPMAK mengusung visi menjadi Center of Excellence dan Trend Center dalam pengembangan sistem, kebijakan, dan implementasi pembiayaan dan asuransi kesehatan di Indonesia. Pusat Kajian KPMAK UGM memiliki misi untuk mengembangkan konsep dan mendorong implementasi sistem pembiayaan dan manajemen asuransi kesehatan melalui riset ilmiah, konsultasi, dan pelatihan, serta pengembangan jaringan di tingkat lokal, regional, maupun global dengan berbagai pemangku kepentingan. Pusat Kebijakan Pembiayaan dan Manajemen Asuransi Kesehatan Universitas Gadjah Mada memiliki 3 haluan program utama. 1. Melaksanakan penelitian berbagai topik yang bertujuan untuk pengembangan konsep kebijakan pembiayaan dan manajemen asuransi atau jaminan kesehatan. 2. Menyelenggarakan pelatihan dan pendidikan berkelanjutan dalam rangka peningkatan kapasitas keilmuan dan keterampilan profesi, baik dalam bentuk short course, thematic skills training, maupun pendidikan postgraduate yang terstruktur. 3. Konsultasi yang diselenggarakan atas permintaan lembaga pemerintah pusat dan daerah untuk melakukan pembenahan kebijakan pembiayaan kesehatan dan manajemen asuransi atau jaminan kesehatan. Adapun cakupan area penelitian ini meliputi health account, penghitungan biaya kesehatan, penganggaran kesehatan, health technology assessment, evaluasi ekonomi dalam program kesehatan, perhitungan remunerasi di fasilitas kesehatan, evaluasi program JKN, utilization review, coordination of benefit.
Pusat KPMAK merupakan salah satu pusat kajian di bawah Fakultas Kedokteran, Kesehatan Masyarakat, dan Keperawatan Universitas Gadjah Mada. Kami memiliki tradisi riset yang kuat terkait dengan berbagai kajian pelayanan kesehatan yang berhubungan dengan pembiayaan kesehatan dan asuransi kesehatan, baik dengan pendekatan makro maupun pendekatan mikro. Sejak kelahirannya di tahun 2000, Pusat KPMAK telah banyak memberikan kontribusi penting baik di tingkat lokal maupun tingkat nasional. Penelitian yang kami lakukan merespons permasalahan terkini, memberikan evidence ke pembuat kebijakan, merepresentasi kebutuhan masyarakat termasuk diantaranya kelompok masyarakat rentan. Hasil kajian diantaranya adalah evaluasi jaminan kesehatan, penghitungan biaya paket layanan kesehatan bagi masyarakat, juga bagi masyarakat berkebutuhan khusus. Diseminasi hasil kajian dilakukan melalui berbagai metode, baik berupa seminar atau workshop, policy brief, media massa, dan berbagai jejaring media sosial. Berkembangnya pusat KPMAK bersama dengan mitra kerja di lingkungan internal UGM maupun mitra kerja eksternal baik dalam maupun luar negeri merupakan kontribusi untuk mewujudkan tridharma perguruan tinggi.
Kami mengembangkan inovasi-inovasi layanan yang akan mendukung berbagai aktivitas di pusat studi KPMAK.
Selain sebagai pusat penelitian dan pengembangan serta inovasi dan publikasi, KPMAK juga bertujuan untuk memberikan bersama dengan minat KPMAK agar terbangun sumber daya manusia yang memahami betul di dalam sistem pembiayaan dan asuransi kesehatan di S2-nya yang merupakan S2 minat asuransi dan jaminan kesehatan pertama di Indonesia. Nah, kita ingin ke depan bahwa KPMAK akan terus berkembang bekerjasama dengan pusat-pusat pembiayaan kesehatan baik di nasional ataupun internasional dan juga bahkan global. Ini ingin ke depan KPMAK terus-menerus berkembang dan bisa memberikan informasi yang terkini dan solusi untuk pembiayaan dan jaminan kesehatan. Sekian, terima kasih. Assalamualaikum warahmatullahi wabarakatuh.
Hi, I'm Rosie. My friend Matt and I are friends with Assistant Professor Witwichadet, who asked us to make this presentation on his behalf, titled Epidemiologists, Essential Workers of the Future. Epidemiologists are health scientists who study the distribution of diseases in a population. Epidemiologists identify health problems, measure their magnitude, identify risk factors, and identify solutions to these problems. So, who should study epidemiology? This discipline is very useful for scientists who are interested in public health. Epidemiology is also useful for public health people who are interested in science. Now my friend Matt will talk to you about the different fields of study within epidemiology. Matt?
Thanks, Rosie. Hi, everyone. I'm Matt. So the word epidemiology might make people think of epidemics or infectious diseases, and they would be right. However, epidemiologists also investigate problems in other fields, including maternal and child health, cancer, mental health, alcohol and substance abuse, and even casualties from violence and armed conflicts.
Graduate education in epidemiology emphasizes data analysis and interpretation, as well as field work and project management. These skills are highly transferable to career fields that are in high demand and deemed as essential for the future. In addition to working as epidemiologists for health departments, graduates of master's and Ph.D. programs in epidemiology are qualified to work and have found employment as data scientists, survey researchers, actuarial scientists, as well as technical consultants for international organizations such as the WHO and UNICEF, especially in the area of monitoring and evaluation.
The curriculum of our master's and Ph.D. programs in epidemiology include basic and applied epidemiology, statistics, qualitative research, and other related skills. During the first year, students take their coursework and gain initial research experience from the week-long field exercise in southern Thailand, before returning to their home country in the second year to conduct research for their own thesis. The research topic can be tailored to the students' and the supervisor's interests. Master's students typically take 2 to 3 years to complete their study, while doctoral students typically take 3 to 5 years.
Thank you for watching our video. We hope that you can join us in Thailand and become a part of our community. Please visit our website for more information. See you soon.
Faculty of Medicine, Public Health and Nursing, Universitas Gadjah Mada has grown rapidly over the years and positioned itself to become a leading institution in Indonesia and in the region. It was established on March 5, 1946 as the oldest Faculty of Medicine in Indonesia. It aims to become an innovative and excellent Faculty of Medicine, Public Health and Nursing with international standards and to always serve the nation and humanity with national cultural values based on Pancasila. The mission of the faculty is to improve public health status through education, research, and excellent services based on local wisdom, ethics, professionalism, and evidence-based science integrated in the academic health system. Various study programs in Faculty of Medicine, Public Health and Nursing, Universitas Gadjah Mada has successfully achieved accreditation, such as TreeAge, Asian University Network Quality Assurance, and Philippine Accrediting Association of Schools, Colleges and Universities at the international level, and the Indonesian Board of National Accreditation for Higher Education and Indonesian Accreditation Agency for Higher Education and Health at the national level. Supported by lecturers, including professors, and supporting staff, departments, research centers or working groups, Universitas Gadjah Mada Academic Hospital, Central Public Hospital, Dr. Suraji Tirtonegoro, and Dr. Sarjito Teaching Hospital, which is currently accredited by Joint Commission International for Academic Medical Center. The faculty offers undergraduate programs, graduate programs, medical specialist programs, and combined degree programs. Every year, over 500 undergraduate students and 600 graduate students are enrolled. The faculty continually develops and improves a flagship program called Continuing Professional Development through guest lectures, seminars, symposia, and workshops. Moreover, the faculty is equipped with IT facilities and information systems that are integrated with the university system, video conference facilities and webinar, a computer-based test room in a convenient academic atmosphere, and a green campus. Supported with comfortable workspaces, museums, sports facilities, and disabled-friendly buildings. Active partnerships and strong collaborations have become inseparable parts of our faculty, without which progress in education, research, and community service would not have been achieved. Our international partnerships create ample opportunities for student and staff exchange, research collaborations, community services, as well as development of international, double degree, and sandwich programs at the undergraduate and graduate level.
As the one of the oldest medical school in Indonesia, we always encourage the quality of interprofessional education, strengthen research collaboration, community services based on local wisdom values, and modern technologies with international standard. Welcome to our Faculty of Medicine, Public Health and Nursing, Universitas Gadjah Mada.
Pusat Kebijakan dan Manajemen Kesehatan atau PKMK merupakan salah satu pusat kajian di bawah Fakultas Kedokteran Universitas Gadjah Mada. Kami berdiri pada tanggal 5 Februari 1998. Seiring berjalannya waktu, kegiatan PKMK yang berawal dari bidang manajemen pelayanan kesehatan beberapa tahun terakhir ini semakin banyak berkembang ke arah kebijakan kesehatan. Hal ini berdampak pada perubahan nama institusi yang semula adalah Pusat Manajemen Pelayanan Kesehatan atau PMPK berubah menjadi Pusat Kebijakan Manajemen Kesehatan atau PKMK. Perubahan ini sesuai dengan persetujuan Senat Fakultas Kedokteran Universitas Gadjah Mada tertanggal 15 Maret 2013. Struktur organisasi PKMK terdiri atas 3 bagian, manajemen, divisi, dan unit pendukung. Manajemen adalah sistem yang mendukung jalannya kegiatan dan secara operasional membantu secara administrasi. Saat ini PKMK mempunyai 5 divisi yang sesuai dengan bidang keilmuannya, yaitu Divisi Manajemen Mutu, Divisi Kebijakan dan Manajemen Kesehatan, Divisi Manajemen Rumah Sakit, Divisi Manajemen Bencana, Divisi Sistem Informasi Kesehatan. Untuk mendukung manajemen dan kelima divisi tersebut, PKMK mempunyai unit pendukung, yaitu unit seminar dan publikasi. Untuk mendukung publikasi, PKMK menggunakan teknologi informasi. Salah satunya adalah penyebaran ilmu berbasis website. PKMK menyebarkan perkembangan ilmu dan informasi melalui website sejak tahun 2010. Website induk yang dikembangkan ialah Kebijakan Kesehatan Indonesia. Setelah itu, dikembangkan beberapa website lain untuk memberi banyak kontribusi terhadap masyarakat luas. Harapannya, website-website ini dapat diakses dan dapat dimanfaatkan seluruh pihak yang membutuhkan. PKMK telah bermitra dengan lembaga-lembaga pemerintah dan swasta, serta lembaga-lembaga internasional seperti SIDA, AUSAID atau DEVAT, WHO, Bank Dunia, European Union, dan USAID.
Pusat Kajian Kebijakan Pembiayaan dan Manajemen Asuransi Kesehatan atau Pusat KPMAK adalah pusat kajian di Fakultas Kedokteran Universitas Gadjah Mada yang fokus pada